you want me to go ahead and share my screen, Nora?
Not yet, Sarah.
Okay.
Deepa, please go ahead.
Oh, sure. Thanks, everybody. Welcome to day 3, the last day of our Global Health MPH Thesis Presentations. I know many of you are here because you share with me quite a bit of pride for our students and all they've accomplished over the last 2 years, or more in some cases, or less. You know, they've faced a lot of challenges over the last year and a half. You know, including not being able to travel to their home countries to collect data, or, you know, having very little idea of what is possible without actual face-to-face data collection. But I feel very strongly that the last 2 days have shown us that so much is possible, a lot is possible. And I think that today you'll hear more of that, all the extraordinary things that our students have done. I wanted to take this time on this last day of thesis presentations to say some thank yous to our amazing staff for their organization and helping the students to get to this point, particularly Noura Yusufa for organizing the last 3 days and advising students, Andreas Kayadara for helping advising as well, and Julie Burnett for organizing all of us. So thank you so much for all of your efforts. And I also wanted to thank all of the amazing mentors who spent a lot of time and energy over the last, 15 months, helping our students see what is possible. And I'm really, I have so much overflowing with joy to see all of the parents and family members here joining us to hear the thesis presentations. Thank you for attending. Just some logistics, and Nora has a handy slide to help us through thinking about formatting and how we're going to do this today. But we have 13 presentations. The students will have 10 minutes to present and 5 minutes for question and answer. Students, keep an ear out for Nora, who will call out the time when you have 5 minutes left, 2 minutes left, and no minutes left. And of course, if you know that you're running late, please adjust accordingly to stay within that 10-minute frame. To the audience, please submit your questions in the chat box. I know, Nora, you may want to add a little more here on, you're going to prioritize, if I remember right, student questions, so we can hear student voices in our discussion. And Nora will also, when we're running out of time in that 5 minutes for Q&A, batch questions. As you can see, we're recording. So if you're not the presenter, please do keep yourself muted. And you have a choice whether or not you want to keep your video on or off, whatever your bandwidth allows, but we'd love to see you. And everyone, please engage and ask questions. We're looking forward to today's presentations. There'll be a break at 11:40 for half an hour. And then we'll all come back at 12:10 to hear the last few presentations. So thanks, everybody. And anything I left out, Nora?
Nope, that was it. That was perfect.
Okay, so we'll have Sarah Smith start things off. The floor is yours.
All right. Hopefully now you can all see my screen. Hi everyone, my name is Sarah Smith, and today I'm going to be sharing some preliminary results from my thesis project entitled Impact of the COVID-19 Pandemic on Persons Living with HIV in Western Washington, examining the lived experiences of social distancing stress, personal buffers, and mental health. And I'd particularly like to thank my thesis committee, Susan Graham and Kristen Bemis-Sophie. I was born and raised in Spokane, Washington. I identify as a white, cisgender, heterosexual female, and I don't have personal experience in managing a chronic illness. However, over the last year, I've really been working in collaboration closely with my thesis committee members, as well as other collaborators who have combined decades of experience working with people living with HIV, both locally and globally. And for those who may not know, people living with HIV who are on effective treatment have the same risk for COVID-19 as their peers who do not have HIV. And given that there is a higher prevalence of common mental disorders and substance use among people living with HIV compared to the general population, and that in fact, poor mental health and substance use are predictors of treatment adherence and other HIV-related outcomes, it's important to understand how the pandemic has impacted their mental health and substance use so that hopefully we can get a better idea of service provision and access if it's been meeting their needs adequately or not. So my research aims through my thesis project are to explore the ways in which COVID-19 has impacted people living with HIV in Western Washington and how personal protective factors or buffers help them cope with these challenges. My second aim is to develop a tailored stress coping model for people living with HIV, and that one that articulates common mechanisms through which COVID-19 social distancing stress impacted mental health and identifies factors that led to successful coping or promoted resilience. So my qualitative study is actually nested within a larger mixed methods research project. And so we started in September 2020 through March 2021, recruiting participants from the University of Washington HIV patient registry via email and telephone so that they might participate in a REDCap online survey. And so some of the main criteria we were looking for were participants that were 18 years or older. They had to be enrolled in HIV care at one of the 5 Madison Clinic sites. Of course, they had to have access to the internet, able to speak English, and consent to participate in the REDCap survey. So after this cross-sectional survey was completed, for each participant, we calculated a COVID stress score, which essentially captured how COVID-19 impacted their daily life, how fearful they were of getting or spreading COVID-19, if they were fearful of COVID-related stigma, and their level of distress from social distancing. And so this COVID stress score in particular allowed us to purposefully sample for in-depth interviews those who had higher levels of COVID stress and lower COVID-related stress. So for the qualitative data collection, all of the participants had to have completed the survey. They had to have access to Zoom or telephone. And then all of the interviews were completed virtually via Zoom between December 2020, and we just wrapped up here in May 2021. All the transcription was done via Otter AI software. And then my colleague Asad Naveed and I had a coding approach that was grounding in the stress coping model I'll share on my next slide. And now I'm in the process of analyzing the data using the framework method and within category descriptions to make within and across case comparisons of those individuals who reported higher versus lower COVID-related stress. So in the beginning of this research project, Susan Graham, as well as other collaborators, had developed this stress coping model. And as you can see on the left, there are many factors that might be potential stressors or sources of trauma. For example, COVID-19 illness, social distancing stress, job loss, or housing challenges. And then in the middle, you'll see coping, things that might help one cope or moderate how severe the stressful events are. So things like COVID-19 knowledge, technology access, and social support. And then you'll see proximal outcomes and distal outcomes. And my research is really focused on how stress and coping is interacting and impacting depressive and anxiety symptoms among people living with HIV. So overall, thus far, we've interviewed 25 participants, 13 that were below the age of 50 and 12 that were above the age of 50. And you can see here that we also oversampled male participants because our overall sampling frame was developed to really reflect the sociodemographics of patients at the Madison Clinic sites. So for example, over 80% of the patients at Madison are identifying as male, and about 66% are identifying as white. So I didn't include racial and ethnic identities here, but overall, of the 25 participants that have been interviewed thus far, 18 are identifying as white.
5 minutes.
So I want to just stress that there are multiple levels of stress, and they go far above and beyond what was captured in the original stress and coping model that I just mentioned earlier. And so I've situated it within a socio-ecological model because many individuals experience stress related to COVID-19, testing experiences, you know, if they had financial stress, if they lost their job or, went through all their savings and then had housing challenges. Then on an interpersonal and community level, many participants expressed that there was social distancing stress, interpersonal stress, caregiving responsibilities that were stressful, as well as, individuals did have family members or loved ones that had complications or passed away from COVID-19. And so that was obviously a significant stressor for them. Then on the systems level, because there were so many changes related to service provision, not only at Harborview, but in all the Madison clinics, system navigation was significantly brought up as a challenge. Not only for the medical system, but also social service provision and navigation. In terms of vaccine rollout, the political climate, of course, and then the COVID-19 information and misinformation, all of these factors were coming out in the data. So alongside and meanwhile, there were many combinations of adaptive and maladaptive coping strategies that individuals were expressing. Things that were, for example, like exercising and staying active, seeking out mental health treatment, meditation. Those were definitely coming up, both in the low and high stress categories of participants. But then there were also more maladaptive strategies such as substance use, gambling, stress baking, and online shopping that certainly did come up again in both low and the high stress categories. So just delving in now to a couple of main themes that I've been seeing in my data is that there's multiple dimensions of social distancing stress. And this is, not just in terms of not seeing family members or friends, but it's also the fact of, not knowing how to support people when they are sick or struggling, or just the lack of activities that were, the activities that were taken away from people, since COVID began. And so this participant says, well, when the COVID first started, the hardest thing for me to do was when I heard stories about family members not being able to visit. When I sent my nephews the email saying that I really needed to stop visiting them, it was really hard. It was really, really, really hard to say, if I get it, chances are very good that I'll die from it. And that's just too big of a risk to take. So in this participant's perspective, it wasn't just that he was, it was painful not being able to see his nephews and family members, but it was also having these life and death conversations over the phone and not being able to see them very often.
2 minutes.
This participant, thank you. This participant was talking about, he had lost his job and then, his gym had closed down. The trails that he was hiking at were no longer available to him. And so for this participant, it did cause him increased substance use and increased anxiety related to that. The second theme I wanted to just mention briefly is the financial security. Maybe not surprising, is an important personal buffer, and it helps people not only, pay for food to be delivered and other services to be delivered, but it also decreases their potential exposures by going to food banks or going outside of their neighborhoods. Then finally, while participants didn't necessarily, the vast majority of participants did not describe substance use, increased substance use or relapse, they did indeed talk about the avoidance of medical facilities and delaying or limiting HIV and non-HIV related appointments. So this woman, she says, again, I'm scared to go. I'm scared to go to the doctor. I have a dentist appointment that I pushed out continuously, and now it's in May. And I started this dentist appointment in, I want to say February. Yeah, my kidney appointment, I delayed that one too. And so we're seeing not just younger generations, but older generations of people living with HIV, similarly limiting or delaying their medical appointments. So in conclusion, there's really a vast array of stressors and coping strategies, even in one person's narrative. And only high-stress participants discussed depression and mental health care. Alcohol, tobacco, and substance use, as I was mentioning, was discussed by participants both in low and high stress categories. And additional analysis of factors most important to stress and coping are ongoing. I just want to thank the study participants, my thesis committee, and of course, the other members of the HIV and study team members. I'd be very happy to take questions at this time. Thank you.
Thanks, Sarah. Fabulous job. Wonderful to hear the results of this study that I've been hearing so much about over the last year. So we will take questions. I will kick it off, especially since you're the first presenter, with a question, if that's okay. It might take a while for people to get warmed up. So my question is, you know, you had some really interesting quotes there, and a little bit of data from the participants on the way that they coped. And I wonder if over time, over the course of the year where you were collecting data, if you found differences in their responding based on coping mechanisms kind of kicking in and that sort of thing.
You know, that's a really interesting question, Deepa. Yeah, I think that there was a difference. It depended, of course, on the participant, but even for example, if they knew someone that had been sick with COVID or had serious complications, for some people that really did make them, you know, more cautious, washing their hands more, you know, staying home more. And then there was also too that, you know, on the other end of it, some people were really consistent with social distancing guidelines. They were really consistent, you know, staying home and getting tested when they felt like they were sick. So it really, yeah, I guess it depended on the person. So yeah, I guess hopefully I answered your question.
Yeah, thank you.
Bernardo raised his hand. Go ahead, Bernardo.
Oh, thanks, Nora. I know, very nice work, Sarah. One question, a dimension that is usually considered in stress studies is the control. So did you have a chance to explore how the control that people have over the situation may affect the stress they receive and the consequences and how to cope with it?
You know, that's a really interesting question. I think what came out actually in the data is even when people were not particularly stressed or didn't perceive their own risk to be particularly high for getting COVID, many participants were stressed by other people in their lives that were more stressed out or were more vigilant than they were. And so I think like interpersonal stress and conflict was something not necessarily in their control, but certainly things that were in their control, like staying home and you know, trying to do everything that they could to stay safe, know their, you know, whether they had COVID or not. That was something that they were in control of, and I think there was more, they were more at ease with that.
Sarah, you have a question from Steve who says, great presentation. Even though your sample was predominantly male, did you see differences among men and women?
You know, I think so. Actually, most of the women that I interviewed had families and they had children of their own. And so caregiving seemed to really come into play with that. And it seemed to also come into play where, you know, women seem to be more, how do I say? You know, actually, it was mixed in terms of whether they went or they, you know, were going to the healthcare facilities or not. But I think overall, caregiving for sure, having family support, that was more consistently with women. And a lot of the males actually were either single or lived on their own. So they kind of had their own configuration of when they were seeing people, if they were seeing people, and how they were coping in general.
Wonderful. Thank you so much for your presentation.
Thanks, Sarah. Okay, sounds like next up is Naziat Karima.
Good morning, everyone. Can you see my screen?
Looks great.
Okay. Good morning, everyone. My name is Naziat Karim. I'm from MPH Global Health General Track. I'm going to present my thesis on estimating low birth weight prevalence and stillbirth rate among pregnant women with HIV. This is a secondary health facility-based cross-sectional study in Manica province. My thesis committee are Dr. Kenneth and Dr. Christiana. I will follow this outline. My motivation to conduct this study among HIV-positive mothers comes from the fact that Mozambique is among the most HIV-affected countries in sub-Saharan Africa. The prevalence of low birth weight in Mozambique is still high, estimated at 13% in 2015. Few recent studies have estimated low birth weight prevalence among HIV-infected women in Mozambique. For this study, we defined two aims. First, we wanted to estimate birth outcomes among newborns born to HIV mothers, particularly the low birth weight and still small for gestational age prevalence and stillbirth rate. Second, we aim to explore maternal, newborn, and facility factors associated with those birth outcomes. We conducted a cross-sectional study using baseline data from SIAS scale study. Patient-level data was abstracted from maternity registries in 36 health facilities with the highest volume in Manica province between January and December 2017. We used HIV-infected mothers who gave birth at 33 maternities as our study primary population. We included mothers with gestational age between 28 and 48 weeks. For low birth weight and small for gestational age estimates, we included liveborns with birth weight between 1 and 5 kilograms. For stillbirth estimates, we included all newborns irrespective of birth weight. In this slide, I have the definition for the study outcomes and predictors. In the interest of time, I will not go over each. For low birth weight, we used the WHO definition with the cutting point at 2.5 kilograms. We present the stillbirth rate per 1,000 births. The antenatal care workload was defined as the average number of first antenatal care visits per maternal and child nurse per day. We defined health facility location based on the 2018 Ministry of Health Service Availability and Readiness Assessment. The analysis was performed at health facility level. We corrected the birth weight between 2,450 grams and 2,550 grams, originally collected in multiples of 50 to reduce misclassification. Binomial exact test was applied to estimate corrected low birth weight prevalence, small for gestational age prevalence, and stillbirth rate. Furthermore, a logistic regression was performed to estimate the odds of low birth weight and small for gestational age associated with predictors. This analysis accounted for clustering at the health facility level. Here are the study summary findings. We did find an overall prevalence of uncorrected and corrected birth weight of 8.7 and 13.2% respectively. The uncorrected for small for gestational age prevalence was 9.4% and did not change after correcting birth weight. We estimated a stillbirth rate of 17 per 1,000 births. In the next slides, I present detailed results. This table shows characteristics of study participants. Our sample has a total of 2,254 pairs mother-baby, from which 299 had birth weight below 2.5 kilos. Overall, participants had between 2 and 5 previous deliveries, gestational age between 37 and 41 weeks, and over 90% initiated IRT during pregnancy. Except gestational age, all other characteristics were balanced in our sample.
5 minutes.
As I explained before, the prevalence of corrected low birth weight is 13.3%. From this plot, we can learn two things. First, higher prevalence was mainly found in districts without a district or provincial hospital. Second, there is a substantial heterogeneity between districts since the prevalence ranged from 9% in Chimoio to 24% in Susundenga. The same pattern previously seen with low birth weight was found with small for gestational age, with districts with no hospitals being the ones with higher volume, higher prevalence of small for gestational age, as you can see in this plot. This plot shows the crude and adjusted odds ratio of each predictor. Using gestational age of 37 to 41 weeks as a reference, we did find an increased risk of low birth weight in women with gestational age below 37 weeks, as we could expect. For small for gestational age, the increased risk was found when gestational age was above 42 weeks. For all other predictors, except preterm, the odds ratio 95 confidence interval included 1. Here are some take-home messages. The estimated low birth weight prevalence is high and is consistent with national and regional prevalence. It's concentrated in rural areas and there is high variability across study facilities. The difference of corrected and uncorrected low birth weight prevalence of 34.6% highlights the potential failures to detect low birth weight cases. The estimated small for gestational age prevalence of 9.3 is below the national and regional estimates, which is 25.5%. The stillbirth rate of 17 per 1,000 births is high, but below the estimated rate for Mozambique, which is 22.7 per 1,000 births. Our study had some limitations. First, we lack information on important covariates. Second, we are not able to generalize the results of this study to the overall HIV population, given that the sample was restricted to only 3 facilities per district in HIV women with institutional deliveries. Despite the limitations, the study has strengths. The analytical approach is robust and enables to understand facility-level heterogeneity. Also, it helps to improve low birth weight and small for gestational age estimates using routine data.
2 minutes.
These study results may have some policy and research implications. They are useful to inform programmatic discussions and policies to improve low birth weight surveillance, improve labor monitoring, and inform future research, including the SIA scale evaluation. I want to end my presentation with a big thank to my thesis committee for the support and guidance throughout the thesis process. I could not have come to this point without the support from someone very special. Many thanks, Steve. I would also like to thank folks from the MPH court, MPH advisors, Orvalho Augusto, and my family and friends. Thank you. I can now take some questions.
Thank you, Naziat. Nice job.
Thank you.
I'll wait to see if people will input their questions, but I do have a quick one to start us off, if that's okay, Naziat.
Yes.
You had on one of your slides as a limitation that you were limited in the covariates that you measured. And my question is about what those covariates might be that weren't measured, but also the predictors. You know, what other factors other than access to a hospital without a high burden of deliveries, what are the other things that might be contributing to these poorer birth outcomes?
Some of the variables that we couldn't include in our analysis where maternal age, for instance, the timing of IRT initiation, and other diseases, for instance, we could have included anemia, hypertension, eclampsia, and syphilis. That could help explaining the outcomes, low birth weight and stillbirth rate. So I think that these 5 or 6 variables could have explained a little bit better some of the findings that we have.
Okay, thanks.
Nazia, you have a question from Bernardo, who has his hand up. Go ahead, Bernardo.
Thanks, Nura. No, very nice work. One question, this finding about the association between gestational age and low birth weight is very important because there are different mechanisms that may contribute to low birth weight. So how would you interpret this association and what recommendations would you do based on this?
The association we found between gestational age and low birth weight and stillbirth and small for gestational age are expected. And my recommendation are expected for preterm, that means gestational age below 37 weeks, and post-term, that's the gestational age above 42 weeks. And my recommendation will be related to including more frequent monitoring of women that have some of the diseases or conditions that could have that are related with these outcomes. We would include, instead of having the visits for women with anemia, with syphilis, with malnutrition or other conditions once a month in the last trimester of the pregnancy, maybe we could include, like, instead of 3 weeks, we could see these women twice a month, for instance.
Thank you.
Thank you, Najat. So Steve has a question. He says, excellent presentation. Why do you think there was so much difference in both SGA and LBW in different districts? Was there an association with percentage of births at facilities?
Yes, Steve. The difference between districts, the first difference we see is that the Susunenga district, that's here, that has the most cases of small for gestational age and low birth weight, is a district that's located in, it's a district with it's high productive district, and it's high productive district, but this is not the only reason that can explain the high levels of low birth weight that they have. They can have access to the food, but the way they prepare or they combine the food in the meal, it's important. And also there is other factors that can contribute, such as the gestational age, such as other conditions that women can have, such as if they initiated or not the IRT. We didn't have like most of the women from these districts, so the deliveries wouldn't count that much in that case to explain the high level of low birth weight and small for gestational age that they have. I don't know if that answered your question, or Steve?
Those are good ideas. It's still much more varied. There's much more of a variability between districts that are pretty similar than I would have expected. And you know, Susan-Denga is a district that has fabulous agricultural potential, for instance, compared to Machazi, and yet the rate is so much higher in Susan-Denga. So just it seems like an odd finding and an interesting one.
I will take some time to explore more of the prevalence in this district in future steps.
Great. No, it's really interesting. Very interesting.
Thank you.
Great. Thank you so much, Nazia. You have a comment from Deepa, but you can go ahead and just respond to her in the chat.
Thank you.
Thank you, Nazia.
Thank you. Okay, next up is Julie Skeen.
Hello.
Nazia, can you unshare your screen?
Sure.
There we go. Let's see. Okay. Can you see my slides?
Sure can.
Great. Okay, so hi everyone, I'm Julie, and thank you for inviting me to share some details about the thesis project I've been working on, which is hepatitis C service provision at Washington State opioid treatment programs. Hepatitis C is the most common infection spread through the blood in the United States. The rates of chronic hepatitis C remain high as initial infections don't always cause symptoms, and many people don't realize they have the virus. If the infection is left untreated, a person is at risk of serious health consequences and even death. This is unfortunate because there's actually an oral medication available that can cure people in just a matter of weeks. In recent years, hepatitis C cases have been rising dramatically among younger people, primarily due to the injection drug use associated with the opioid epidemic. So to address the growing problem, Governor Inslee issued a directive for the state to develop a plan to prevent transmission of the virus, increase the number of people that have access to treatment. So in response to that directive, the Hep C Free Washington initiative was developed, and it has a mission of eliminating hepatitis C in Washington State by the year 2030. And inside that initiative, one of the recommended actions is for opioid treatment programs to expand their services to include HCV or hepatitis C testing and treatment on site. So my thesis project focused on this particular recommendation and assessed the program's progress towards this goal. The assessment was requested by the Department of Health to inform future collaborations with the programs and find out how they could strategically support them in the future. So my study aims were to describe general characteristics of these programs, assess their scope of infectious disease testing and treatment with an emphasis on HCV services, and determine medical directors and administrators' self-ratings of their awareness of HCV initiatives and guidelines, their reported comfort level discussing hepatitis C with the program staff, and their continuing education interests in HCV-related topics. Programs that were eligible for inclusion in the study were behavioral health treatment agencies licensed by both the state and federal government, They're the only outpatient treatment type where individuals can receive all 3 medications for opioid use disorder. Data was collected utilizing 2 electronic surveys that were developed in REDCap. One survey was completed by program administrators, and then the other survey was completed by medical directors. The questions in the surveys overlap to some degree, but they were also customized to take advantage of each professional's expertise in specific areas. Once we got those results back, descriptive statistics, including counts and proportions, were generated to quantify survey responses. We calculated the mean and standard deviation, or median and interquartile ranges for those with continuous outcomes. And before I move on to talking about the results of the surveys, I want to take a moment to reflect on my positionality within this project. As a white person here in Seattle, I was at ease working with the government agency like the Department of Health and the university. I don't regularly experience institutional racism and bias. And then I'm a nurse, so I'm also really comfortable navigating the healthcare system. I understand the medical terminology and clinical procedures. And I'm also healthy, middle class. I have access to healthcare, so I lack lived experience with hepatitis C infections and substance use treatment disorder. And I understand that my roles and position are important to consider in a study like this, as they can influence my research and lead to bias. So the survey respondents included 9 medical directors and 18 administrators that represented 22 programs from across almost all regions of Washington state. The majority of respondents were located in the Puget Sound area, which you can see on the map. And there was at least 1 medical director or administrator from each of the other regions, except the North Central area. 18 administrators provided information about the general program characteristics in their survey, which are summarized in this table. There was wide variation across programs regarding their years of service, physical size, and client to staff ratios. And on the medical director's survey, 9 provided information about hepatitis C services, their programs provide, and the location of those services. So the column that is integrated is services that are provided directly by program staff. The co-located services are provided by another department or agency on site. And then the services that are not offered are typically available to clients by referral. Survey results show that most programs do offer HCV testing and treatment on site, and that's either integrated or co-located. Most often, programs utilize the RNA type of HCV testing, and the providers that work in these programs are usually specialized in addiction medicine, but they can also treat HCV. And there's only 1 program that reported they actually have, on-site access to a specialized provider for hepatitis. And many of the programs test and treat other infectious diseases as well. The most frequently reported testing was for tuberculosis and syphilis. HIV testing is also common. 88.9% of the programs said they offer that testing. The most common treatment that was on site was for chlamydia, gonorrhea, and syphilis. Tuberculosis treatment and HIV were less common. And 5 of the 9 programs said they offer preventive hepatitis immunizations on site. The respondents also self-rated their awareness of specific policies and guidelines. The medical directors were found to be at least moderately aware of all the topics included in the survey. The director's confidence in the topics was reflected in their lack of desire for additional information. 75% of them indicated they do not wish to receive future education about these policies and guidelines. The administrators' responses indicate that in general, the group is less familiar with HCV policies and guidelines, and they are more interested in future education on these topics. The respondents also provided information about some barriers they've experienced to integrating HCV care. And these occurred across all levels of the healthcare system. On an organizational level, they mentioned lack of standardized protocols, and the reimbursement levels varied widely between the programs and impacted the scope of services they could provide. At the clinic level, there were reported difficulties managing blood draws to get tests, and it was compounded by laboratory hindrances like limits on supplies, time deadlines, and costs. And also staffing levels, if they're not adequate to support both opioid use disorder and HCV, the providers said they experienced, a lack of time due to the competing responsibilities. And on the individual client level, they reported, clients with past traumas that resulted in needle phobias, fear, difficulty navigating the healthcare system, and lack of urgency to get treatment due to the asymptomatic nature of the infection.
1 minute.
Okay, so the results of the surveys indicated that the programs are making significant progress towards the Hep C free Washington goals, with half of them offering integrated HCV care. And it's quite remarkable given how variable they are in their characteristics. The participants reported high levels of awareness about HCV and the initiatives, and also said they're most interested in learning about reimbursement strategies for HCV care. So going forward, the Department of Health will utilize this information to, plan how to support these programs, which will likely include increased case management and educational opportunities. The limitations of the study were it was a pretty small sample. Most of the respondents were from urban areas, especially the Puget Sound. And the administrator's survey was missing some data, as most of the administrators didn't answer every single question. And so just to conclude, I really want to say thank you to everybody that supported this project. My thesis chair, Pamela Kohler, and my partners at the Washington State Department of Health. And I got some input from the Washington State Healthcare Authority as well. And that's it. So thank you. I'm happy to answer any questions.
Oh, Julie, nice job. I particularly like the multi-level nature of the work that you conducted. So really nice. And what a coincidence that May is Hepatitis Awareness Month, huh?
I know, I saw that. I gotta throw it in there while I can.
I have a quick question for you because I don't see any hands up or things in the chat. You pointed to some kind of structural level factors, and I wonder if, elevated drug prices or for treatment of hepatitis C was anything that kind of came about in your work that, program directors might have expressed as a challenge. I've been thinking about this a lot lately, because of the vaccine access and pharmaceuticals and things like that. And we know, the same things have happened with HIV. So I wonder if anybody discussed that.
It came up a little bit, but not in detail. And I'd actually like to learn more about that in the next month or so while I continue to work on the thesis. There was a theme of needing more information about reimbursement throughout all programs, especially those small independent ones that don't have a large healthcare organization sort of managing, how to get these medications that may be expensive and, and I think that, the Washington State Healthcare Authority is working really hard to get coverage, by Apple Healthcare and other things for the medications because they can be so costly. But I don't know if that information is trickling all the way down to the clinics to where they know how to, what paperwork to submit or, how to integrate into their computer systems, their electronic health records. So I think, there's a little bit of lack of coordination. And, I'm sure the pricing of these medications plays into that. So that's a great question.
Thank you.
Yeah.
So Julie, you have a question from Steve who says, a very nice presentation. How will you use your results to improve the situation?
So what they want to do is I'm going to, present these to the Washington State Healthcare Authority, who realizes that there's a problem and they're and the Department of Health, because what they want to figure out is what support should they offer to these programs that will really make a difference, maybe at the system level, so that it's, everybody has access to treatment and we can really get rid of hepatitis in Washington state. So yeah, I plan to disseminate the results to those two organizations, and I've been working closely with them throughout this whole process. And they do have some resources that they can offer, mostly in the way of case management, which seems to be a big problem, because it could really help with, connecting clients to care, or, making sure that they get followed up if they need treatment. And the Department of Health is also available to provide information to these clinics that are out in the community about how to get reimbursement, how to, there was talk of like having directly observed medication therapy, rather than like writing a prescription for hepatitis C medication and having these clients, try to get to the pharmacy and then remember to take the medication. So, if they could come up with plans and information about how to get maybe the pharmaceuticals right there on site and then actually administer them on site, I think, strategies like that could make a big difference. So we just need to find out exactly what strategies are needed. Hopefully that answers the question.
Yeah, very well, thanks.
Yeah, thanks, Steve.
Great job, Julie. Thank you so much.
Yeah, thank you. Nice to see all of you. Here, I'll stop share.
Great, thanks.
Yay.
Next up, we have Cecilia Tembe.
Good morning, everyone.
Good morning.
You all hear me? Can you see my presentation?
Yep.
Okay, thank you. I'm going to start. Good morning, everyone. My name is Cecilia Tembe, and I am going to present my thesis. I am a Global Health General Track program, and the thesis is on assessing healthcare provider competencies to diagnose and treat children under 5 years of age with acute disease in central Mozambique. My committee is, or our Kenneth Chair is the chair, Sarah Gimbel and Kinesh Fernandes are the members of my thesis committee also. This is the presentation outline, and I'm going to focus on background, analytical framework, aims, methods, results, discussion, and conclusion. In the last 25 years, under 5 mortality has significantly dropped at the global level. However, it remains at unacceptably high levels in Mozambique, with 73 deaths per 1,000 live births. Encouragingly, primary healthcare utilization is high in Mozambique. Evidence-based interventions to address causes of under 5 mortality, including guidelines, which operationalize national policy. However, implementation of guidelines and universal adherence to them in Mozambique are still a challenging. In the service delivery indicators, health survey conducted in 2014 by the World Bank in Mozambique showed that only 37% of healthcare workers adhere to clinical guidelines for the management of 3 childhood conditions, and also showed that only 30% of the providers adhere to the guidelines used to prevent maternal and neonatal complications. Therefore, improving the adoption and implementation of the Ministry of Health clinical guidelines can leverage high health service utilization, reaching broad scale to address principal causes of neonatal deaths. This is the analytical framework that I have adapted from Africa Health Service Delivery Indicators. And here I just wanted to communicate or show the scope of this work, and also to highlight some of the characteristics that I've used, such as training, working condition, type of health facility that I've included in the analysis. And as you can see here in the output, both improved knowledge of clinical guidelines and improved adherence to clinical guidelines are considered essential for a competent provider. The study aims, here I have one to describe healthcare provider and health facility characteristics in central Mozambique. And the second aim was to assess healthcare provider competencies to manage pediatric illness, including 2.1, providers' knowledge and adherence to national pediatric care guidelines, and 2.2, health facility and provider characteristics associated with adherence to clinical guidelines. This was a cross-sectional study design nested within an annual longitudinal health facility survey, which is being conducted by the IDEAS intervention in 4 provinces in central Mozambique. We included here a sample of 550 health care providers assessed for the first time in the 3 rounds of the intervention so far. I have to say here that this is a longitudinal intervention, but here for this study, which is cross-sectional, we only use the first observation or the first assessment of each of the providers. Data collectors included trained and experienced nurses, maternal and child health nurses or clinician officers. To assess knowledge of guidelines, we used vignettes, and which are case studies, and we have 2 case studies focusing in identifying signs of disease severity. To assess adherence to guidelines, we use direct observation of providers to determine if they asked the 5 danger sign assessment questions during the at-risk child visit. The main outcomes in this study were identification of danger signs in under 5 child mortality, under 5 child via vignettes, and adherence to guidelines during direct observation. As predictors, we have, thank you, gender of the providers, age in years, had training in the last 6 months, years since graduation, professional cadre, worked extra time, health facility location. The data management included a data set in which at first we had multiple signs per provider in the wide format, but then we had to reshape to a long format where we ended up having multiple observations per provider, 1 column to identify the item and 1 column with response for the item. We used the mixed effects logistic regression with random intercepts for the provider and the item, as you can see in this complicated equation. And we have factor here for all the predictors that we included in the analysis. As results, for the first aim, which were to characterize providers and health facilities, we found that 70% of the providers were female with a median age of 30 years. 39% of them had training in the last 6 months. 31% had less than 2 years of experience. 23% said they worked overtime recently, and 50% of the providers were maternal and child health nurses, which is something that we already expected. 76% of the health facilities are located in rural areas. The second aim, first we had to assess knowledge, and we used through vignettes. We found that 93 and 100% of the providers correctly identified any danger sign, as you can see in the table. But oddly, we also found 67% of the providers identified other danger signs. This is not something that we expected or we had to expect. I'm just highlighting here just to call attention also in the results. For the adherence, we found that of the 122 providers assessed, overall showed low adherence, as you can see in the table. Lower percentage of providers correctly checked for any of the danger sign. To answer the association of provider and health facility with adherence to the clinical guidelines, after adjusting for the characteristics included in the analysis, we only found a meaningful association in the professional cadre category with preventive and clinician officers having 39 less odds of correctly identifying any danger signs in the vignettes. In here, we had nurses as a reference group.
Few minutes.
The discussion, thank you. Respondents were able to correctly identify danger signs in vignettes, but did not assess children for danger signs under direct observation. Maternal and child health nurses were more likely than other cadres to correctly identify danger signs in children under direct observation. As limitations, the use of vignettes does not represent how providers perform or can perform in the real world. Also, we may expect some observation bias with the direct observation where the data collector may sometimes check only based on his best judgment of what is correct and what's wrong. As strength is, I think, my positionality as Mozambican physician with experience in working with the Minister of Health and also mentoring maternal and child health providers in the districts, I think it's a strength. And also these results can be useful information for the Minister of Health for better planning and what to focus, in this case, adherence. Conclusion, where evidence-based clinical guidelines exist to more efficiently and effectively identify acute health conditions in children under 5 years, such as in Mozambique, further efforts to improve healthcare provider adherence to clinical guidelines are needed. Additionally, further research is needed to identify additional drivers beyond training of clinical guidelines adoption across healthcare provider cadres. I wanted to finish acknowledging the IDEAS project and the team in Mozambique, my thesis committee, a special gratitude to our value, Department of Global Health, HAI, and my family and friends. Thank you.
Thank you, Stelio. Nice work.
Thank you.
Okay, I do see a question here. I know you're going to have a couple of questions, so I'll defer to the ones coming into the chat rather than asking my own. But if there's time, I do have a question.
Okay, so let's start with Matt, who says, great presentations, great presentation. What do you think drove the differences between MCH nurses and clinical officers?
Okay, great question. I think something which is lacking in Mozambique especially is lack of accountability, especially for other professional cadres. They think this child care, under 5 child care is more for the maternal and child health nurses. So they tend to not do the best of what they could do. And this is what we expect in like with these results. As we can see, maternal and child health had better performance with adherence to protocols, even with knowledge compared to other professional cadre.
Great, thank you. And you have a question from Bernardo, who has his hand up.
Thanks, Nura. No, very interesting work, Stelo, and really shocking. I mean, imagine if the adherence, considering the observation bias you mentioned, if the adherence is low when you were observing them, imagine when you are not observing. But so the big question here is, if the knowledge is okay, why they are not adhering? If there is an organizational problem, if there is a problem with inputs, an overload problem, do you have any guess of what is happening?
Yes, I think well, what we had, or what I had first, and that's why we included here most of these characteristics related to the health facility and also with the providers. First was to identify what can, because I was expecting, I think, this kind of results, this sort of results. And I think what really, being in a rural health facility, for instance, it can contribute for this health provider not to feel accountable in giving a better assistance to this child. So these are some of the factors or features that we have to account for. And that's why in the recommendations, I think we have to include in this study or in these results at least some recommendations to the Minister of Health to more focus in the adherence, because we already know that the professionals or they overall, they know, they have the knowledge, but they are not adhering to this knowledge. Thank you. Great question.
So Celia, you have a question from Steve who says, how is the background 37% over 30% adherence to guidelines measured? It seemed very low. What aspects of clinical care did they not adhere to? And why do you think the nurses in the study did better on vignettes than in observations?
Okay, I think I'm going to start with the second question. Also, again, I think I have to say this lack of accountability, I think, is what we, or the Ministry of Health, has to focus more. I think in general, we don't have, or the Ministry of Health doesn't have like better approaches to account for this lack of accountability. We know that they have knowledge of the national guidelines, but they are not, they don't feel this pressure of having to demonstrate a good assistant to the child. This is one thing. And with the study, can you repeat the question? I didn't.
Maybe I should say it. In your introduction, you mentioned that 37% adhered to the guidelines for the childhood and 30% for MCH. That's incredibly low. And so I guess, so my question is, how is that measured? Did it mean that they didn't, write something very unimportant down, and that made it so that they didn't adhere to standards, or were these important things that they didn't actually adhere to?
So one thing is the methods they used in this particular survey to measure the adherence, and they used direct observation also. One thing is, as even in this study, we found that many of, they chose other signs. And I think the person who is collecting the data or is assessing this provider sometimes may be biased, or maybe, when he's checking on the list, because he's observing the provider doing all the procedures. And sometimes he's like, okay, what of those 5 questions that he had to identify the danger signs, if he didn't identify, he puts on other, and that may contribute to these lower percentages, I think.
Okay, thanks.
Thank you.
Thank you, Stelio. Good job.
Thank you.
And oh, I forgot, there's a question from Deepa, if you don't mind answering that in the chat box.
Sure,
as well.
sure.
Thank you.
I had to put my question in there. But thank you so much, Celio. So next up is Jen Emmett.
Okay.
So the floor is yours, Jen.
All right, can everyone see my screen?
Yes.
Okay, thank you. All right, so hi, thank you all so much for being here. My name is Jen, and I'll be presenting my research on the role that religion plays as one of the social determinants of health for displaced populations in South Asia. My thesis chair is Dr. Deepa Rao, and my second committee member is Dr. Christian Novetsky in the Jackson School of International Studies. So to give some background, I am a concurrent student in the Department of Global Health and the Jackson School of International Studies, and my primary areas of interest are international migration and mental health. This project is a systematic review that explores the relationship between religion and mental health in refugee, asylee, and internally displaced populations throughout South Asia. There's a long history of protracted conflict and occupation in South Asia, and religion is deeply intertwined with social and political conflicts. As a result, religion has been a driving factor behind both voluntary migration and forced displacement. The relationship between religion and mental health is extremely complex, and the purpose of this review is to assess the ways that religious identity and practice are linked with both protective factors and risk factors for mental health. So my positionality as a researcher, I am a non-South Asian researcher based in the US. I understand that my perspective on mental health may differ quite considerably from South Asian perspectives. Although I have completed coursework in South Asian history, religion, and culture, I'm aware that the majority of my knowledge has been acquired indirectly through secondary sources. And therefore, my lived experiences may not resemble those of the populations that I'm studying. Additionally, I'm immersed in a culture that recognizes a variety of mental health disorders, and for the most part encourages openness and transparency around mental health issues. While a number of mental illnesses do carry stigma, my personal experience with mental health stigma has been fairly minimal. The specific aims of the study are to identify and describe the ways in which religion is associated with risk factors and protective factors for mental health disorders among religious minorities and migrant populations in South Asia. Initially, the study design included only refugee populations, but we chose to broaden the scope to include a wider range of studies and capture the role that religion plays in the mental health of marginalized groups throughout South Asia. These were our specific aims. Because this is a systematic review, we used pre-existing data gathered in one of the 8 countries included in the South Asian Association for Regional Cooperation, or SAARC. So they include India, Nepal, Bangladesh, Afghanistan, Sri Lanka, Pakistan, Maldives, and Bhutan. The analysis team consisted of me and a second student researcher who's also in the Department of Global Health and the Jackson School and focuses primarily on South Asia. My thesis chair, Dr. Deepa Rao, acted as the third investigator for this project. She provided feedback on the study design, resolved discrepancies around the application of exclusion criteria throughout our article screening process, and oversaw the development of the coding matrix that we used. We searched 4 research databases to generate results. They were PubMed, Embase, PsycInfo, and Web of Science, using the search term that you see on the left side of this table. Essentially, there were 4 components to the search. So we wanted to identify articles that focused on one of the 8 countries in the SAARC region. We wanted to look for religious identity, some mention of religious identity, minority or migrant status, and mental health. And our exclusion criteria are listed on the opposite side of the table here. Here's an overview of our screening process using the Covidence software. So our Boolean search generated 962 results across the 4 databases that we used. Of those, 94 studies were duplicates that the software automatically removed. We then screened the titles and abstracts of the remaining 868 studies, of which we excluded 799. Finally, we screened 69 studies for eligibility during the full text review, excluded 45 for the reasons that you see on the right side of the flowchart. It should be noted that there were 6 duplicate studies that the software didn't automatically remove, so we excluded them manually at this stage. And our final set of articles consisted of 24 studies. On this slide, I've provided a breakdown of relevant characteristics of the 24 studies that we coded in our final data set. Overall, 2/3 of the studies were conducted in either India or Sri Lanka. About a quarter of the studies recruited participants from multiple countries or countries that weren't specified. However, when the country of origin was explicitly stated, we found that a notable percentage of participants had also migrated from India and Sri Lanka, with smaller percentages from other countries throughout South Asia and Southeast Asia. Nearly half of the participants identified as Hindu. I've included several other demographic characteristics that frequently appeared in the studies that we coded at the bottom here, on the bottom right. So I used thematic analysis to develop a deductive coding matrix using an initial subset of 6 studies. The codes are categorized into 3 code families based on our specific aims. So we applied codes related to protective factors, risk factors, and associations or experiences with mental health. Blind coding was done by me and the same student researcher who had assisted with our screening process, so she was already familiar with the study design and objectives. Discrepancies in our final coding are being resolved by our third investigator. This is the list of codes that we used. Several codes were added or modified to accommodate salient themes that emerged that weren't captured by existing codes in our coding matrix. Overall, we found that codes for protective factors occurred with the greatest frequency, as the vast majority of studies we analyzed focused on the increased resiliency of displaced people who belong to religious groups or faith communities. We also found that the majority of studies mentioned participants experiencing anxiety or depression. The preliminary themes we have identified are interactions between religious identity, socioeconomic and environmental factors that influence susceptibility to mental illness, as well as protective factors that are either extrinsic or intrinsic to minority groups. For example, extrinsic factors include the availability and accessibility of psychological support services from aid organizations, whereas intrinsic factors include unique spiritual beliefs or practices within religious communities that contribute to resilience and safeguard against mental illness. So in summary, our data suggests that culturally relevant interventions informed by religious beliefs and practices can promote resilience in displaced populations, and that having opportunities to bond with community members of the same faith and participate in rituals and festivals is an important factor in recovering from trauma. Additionally, reducing stigma and discrimination on the basis of religion and increasing access to legal services and education can help mitigate risk for mental illness. We recognize that this study had a number of limitations. First and foremost, the scope of the study is quite large. We analyzed data collected throughout an entire region and looked at studies on populations with a diverse range of unique identities and characteristics. We also used research databases primarily focused on the health sciences and included studies that used a mix of quantitative and qualitative methods. Because many displaced populations are highly vulnerable, data collection can be a challenge and can be quite time-consuming, which naturally leads to a shortage of data in this area. And we only had access to data that has been published, so publication bias constitutes another limitation of the analysis. I want to acknowledge Dr. Deepa Rao, who is my thesis chair, and Dr. Christian Novetsky, who's my second committee member. They've been incredibly supportive and flexible working with me throughout this process. Miranda Benson, who is my second screener and coder, who has been a tremendous help. The UW-UBC Mobility Award, which provided funding for the Covenant software that we used, and UW faculty members and my amazing cohort. This is a photo that I took 2 years ago while I was studying in West Bengal. And I just wanted to share it here because even though I was there attending a language study program, one of my biggest takeaways from the experience was the incredible amount of diversity that I witnessed. And that was something that inspired me to work on this project. Thank you.
Thank you, Jen. So nice to hear about travel that seems so far away that, but it continues to inspire. I'm gonna just pause and see if there are questions.
Yes, we have a question from Steve. Steve says, great presentation, Jen. Your description of how you did the systematic review was very well done. To what extent did you note an impact of religious NGOs, positive or negative, on health and social determinants of health?
Yeah, that's a great question. Most of the studies that we analyzed noted a positive impact of religious faith-based organizations. It wasn't one of our specific study aims to look for that, but that is an area of interest of mine and actually what my original thesis project was going to look at. So something that is particularly important to me, but for the most part in this study, we noted a positive, relatively positive correlation, but it wasn't something that we focused on.
Any other questions for Jen? Any students? Deepa, you may have to ask your question. Oh, Sarah does. Okay, great. So Sarah Smith says, thanks so much, Jen, great work. Did you include or review publications that weren't in English?
We did not. We excluded studies that were not published in English. We had one study that got through the title and abstract screening because the abstract had been translated into English. But when we went to do the full text review, we realized that the original publication was, I think, in French. So that one was the one on this slide that was excluded for not being in English.
Okay.
And that also is another limitation of the study.
Great. Christian, you have a question? Please feel free to ask Jen directly.
Thanks. Thank you. Thanks, Jen, for this. It's great to see how this work is coming along. I think any questions of this nature that are about this broad category of religion need to also have a kind of intersectional approach that that thinks about what, say, a ritual, who is included or excluded from a ritual. And in this case, I think as you deepen this work, you'll want to think about how caste or gender, those two factors in particular, are recognized or not recognized. So in those 24 studies, it would be fascinating to know if the people who conduct the studies are asking questions about caste, or if they're noting things about gender, because this sphere of religion that you're articulating does have this kind of force of cohesion, but it also has this other force, right, of segregation, separation, disenfranchisement, and so on, which also is part of that discourse of religion, as much as any inclusive kind of sentiment is. So just as a preliminary to that, I'm wondering if you noted this, and if you did, what kinds of things you noted about caste and gender in these studies.
Yeah, absolutely. That's a really great point. And so Deepa and I, when we were going over exclusion criteria, decided to exclude studies that focused heavily on caste, just because there are so many other implications. And we were worried about making the scope of the study even larger. However, I did notice that it came up in several of the studies that we've coded. Gender also has been a really salient theme in a lot of the literature. There were several studies that focused on women who were head of households or had been widowed as a result of conflict and the discrimination that they faced. And unfortunately, mental health treatment outcomes for women seem to be worse. That is another trend that we noticed. But I completely agree with everything that you said, and thank you for raising that point.
If you don't mind, might I take just a little second to add, caste is so huge, is so huge that we thought it deserved like its own paper and analysis. But the other thing to consider is something I've been hearing about over the last few years as I conduct health research in India, is that we need to tread the issue of caste very, very carefully, because if not to get political, but oftentimes we have seen our colleagues in India be defunded or not allowed to conduct their research if they have any implications in their publicly facing papers, websites, et cetera, that suggest that there is any oppression of lower castes that contribute to health outcomes. It's a very, very sensitive topic. So that's another kind of reason why we kind of steered away. But I think it's worth a lot more discussion, and I hope that we can open these dialogues in the future.
Thank you, Deepa.
I know we're probably out of time, right, Nora?
Yeah, we're out of time.
Okay, great job, Jen. Thanks
so much.
Great job.
Okay, so next up is Matt Ahrens.
Hi, everyone. I'm going to share my screen here. I'm presuming everyone can hear me, right?
Yes, we can.
Excellent. Okay, great. So my work for my thesis is on the impact of the COVID pandemic and the associated suppression measures from that on the burden of tuberculosis in India. I'm an MPH candidate in the health metrics and evaluation tract, and my thesis committee included Wei-Q, Peng Zhang, and Theo Voss, who were kind of central to this work. I'm going to start by simply acknowledging my position and my privilege. I'm white, I'm a man, I'm a US-based researcher, and I've been born with all the socioeconomic privilege that goes along with that. In addition, even though I've worked in tuberculosis care and research internationally, I have limited experience in TB case finding and care in India. And so I'm aware that I'm not an expert on this thesis that I'm presenting. And as a result, trying to engage with Indian researchers as kind of the next step so that we can better understand the assumptions and the implications of what we're finding prior to any attempt at publication. So I'll start with an introduction. There have been 10 million incident cases of tuberculosis in the world in 2019, and about 70% of that was focused in Southeast Asia and Africa. India, by far, has the highest burden of tuberculosis and accounts for about 26% of all cases of tuberculosis globally. That amounts to about 1.3 million cases and 440,000 deaths related to tuberculosis in 2019. But despite that history, the National TB Elimination Program in India has made some really significant strides in improving TB care. Here, I demonstrate the change in mortality per 100,000 population in India between 2015 and 2019. And in all states other than Assam, the mortality rate has been decreasing. And in addition, the gap between TB case finding, the number of people who have TB and the number who get identified and start on treatment, has been shrinking. So India has made a lot of really great strides over the previous 5 years in improving TB care and diagnosis. But then 2020 occurred, the COVID pandemic changed public health officials in India and across the world availability to access, diagnose, and care for patients with TB. And some models from early in the pandemic suggested that there would be a significant impact of major and prolonged service disruptions in TB on TB cases and deaths in the months and years to come. Some limited subnational data globally from Migliori and others from the WHO suggested that the impact of lockdown measures on personnel and resource allocation would cause a 50 to 70% decrease in TB services, at least in the short term, and result in marked decrease in ability to diagnose TB in multiple countries. However, also interestingly, another thing that changed in 2020 was that more individuals were wearing face masks, people were less mobile than they had been, and these factors may actually have a protective effect in decreasing transmission of TB. And so my thesis is kind of a first step at trying to quantify how much these different measures have impacted TB case identification, and also what factors can best characterize that disruption of TB services that we know is occurring. And it's a first step towards understanding how the impact has impacted the burden of tuberculosis in India and then more broadly. So these are, thank you. These are my aims. First, to describe changes in TB case notification in India due to the pandemic. And then second, to characterize the impact of these service interruptions and COVID-19 suppression measures on TB case notification. So these are my methods. I started with NICSHE data. NICSHE is the publicly available online database for case notification in India. They have data from 2017 through current data by state in India and by month. For my first step, I modeled the counterfactual of what would be expected for TB cases in 2020 in the absence of the COVID-19 pandemic. And we did that using RegMod, which is an IHME mathematical model, and then compute the ratio of reported to expected cases by state and by month. And then for step 2, we use that output to evaluate the impact of mask use and mobility on this prediction of that disparity in case finding or case reporting. And then we decompose that explained variance. So I'll start with kind of a broad graph. This is just comparison by state in India in 2019 and 2020 of total TB cases notified. And you can see across the country, there was a marked decrease in case notification, anywhere from 15 to 40%. But this figure doesn't really tell the whole story. And when we looked by month over time, you can see a few different patterns. So the top graph here, the gray dots demonstrate case notification for all of India by month and by year. And you can see that those numbers follow a seasonal trend, and at least prior to 2020. And so the blue line is our fixed model based on those seasonal trends. And that's relevant because if we just average the overall yearly numbers, then we miss how much this difference impacts by month estimates. And so you can see the pretty significant drop off in 2020. The second graph here simply represents the time trend, which allows us to fit our model, and also the variance, which factors in seasonality and helps kind of inform our first model. And this seasonal variation we saw in almost every state that we looked at in India. You can see this is in Uttar Pradesh, a relatively large rural state, and also in Delhi, which is more urban, higher population density and higher income as well.
2 minutes.
Thank you. And so when we looked at the ratio of reported to expected cases, we saw that in most states across India, they were pretty significantly decreased. I'll point out 3 states that are relevant. Uttar Pradesh and Madhya Pradesh both had rural areas with low access to resources. There were marked gaps there. But we also saw in more urban states that there was a pretty significant drop too. And what this amounted to in India was that there were at least 1 million TB cases that were not identified in 2020 that we would have expected should have been. When we then looked at the variance and mobility and mask use, what our regression model found was that about 41% of the variance was explained by these 2 factors, and the majority of that was explained by mobility. And so what that means is that measuring mobility is a good surrogate measure for suppression of access to TB diagnosis. And that makes sense. If there are lockdown measures, if there's decreased mobility, people are not going to reach their doctor and get diagnosed. So with that, my conclusions are that TB case reporting in India has dropped significantly across most states, with a gap of over 1 million active cases that should have been reported that were not. Given the early data from 2021 and everything that is going on with the ongoing pandemic in India, this trend is likely to continue. And while there are multiple variables that contributed to the variance in case reporting, decreased mobility really was the best factor as a surrogate measure for suppression of TB-related services. I mentioned that there's likely a protective effect of mask wearing and social distancing in TB transmission. We expect those factors probably will explain more long-term trends, but based on TB epidemiology, are less likely to explain the early trends we saw, which explain about 75% of the drop in 2020. And I can go into that more, but I'm trying to kind of quickly get through my points. Multiple other factors may be important, and we're factoring those in future models as far as covariates to better inform our analysis. And then lastly, future application of these methods in other high-burden TB countries will be kind of the key first step in beginning to characterize the severity of the drop in TB case finding globally and the resultant burden on cases and deaths in the coming years. So with that, again, I will thank my thesis committee, who I mentioned earlier and were amazing, and take time for questions.
Thank you very much, Matt. Very interesting work that you've presented. I have a quick question for you, just to get things warmed up. Did you look at or see any information on COVID-19, the pandemic's impact on treatment, directly observed therapy and whatnot?
Yeah, it's a great question. I think the reality is many of these questions the data is very limited in what's accessible. So we know some data that success rates for treatment by year have dropped significantly in India. We don't have that data, for instance, by state and by date. And so our ability to kind of inform this model with that was impaired. That being said, one of the ways in which the WHO, that study I recommended earlier, described a difference or an impact on TB care services is repurposing of personnel and decreased access to drugs. And so certainly treatment is going to be significantly impaired by this. And especially in areas where there's already a high burden of multi-drug resistant TB, the risk is that that's going to kind of propagate that risk where people are on treatment and then off. But there's still not enough data to really say how significant that drop is.
Thank you.
Matt, you have a question from Gift, who says, how do you think antibiotic resistance is driving persistence TB in India?
Yeah, it's a good question. I think, and a really complicated one. I know that fluoroquinolones are a drug that's now used commonly for drug-resistant TB, has been common in certain parts of India. And the issue around antimicrobial resistance, which I know we've all heard about, is only getting worse. And so there is some data, though I don't know of data from India. There's some data from Kenya I know of, which shows that those two factors are related, that individuals who are more likely to prescribe, or areas where a fluoroquinolone is more likely to be prescribed, that will factor in to drug resistance. In India, most people are treated with first-line TB drugs, which are not characteristically used for other infections. And so I think in those instances, it shouldn't be as big a direct impact. But yeah, I don't know of any perfect or kind of current data that addresses that directly.
Okay. You have a question from Bernardo, who has his hand up.
Thank you, Matt. Great work. Really, TB is a little bit like a ghost. It's so difficult, the reporting, that sometimes it's easy to confuse the progress in the fight against the disease with the problems in reporting. But what would be like your forecast for the future? I mean, as the pandemic of COVID is getting really bad in India now, what would you expect later, like a catch up in the number of cases, changes in the reporting? Any ideas?
Yeah, I think probably a first step in many areas will be ideally some type of surveillance study, because I think some of this we're going to have to start over a little bit. I think to me, there's been a lot of discussion around what services are going to be most important in that catch up idea that you mentioned. And that will really depend on how much service disruption impacts latent TB, how much it impacts morbidity and mortality related to active TB. And so those are kind of two issues that are separate but are interrelated. They have very different implications on, for instance, case finding, contact investigation in the community. And I think probably what's going to happen is the first factors that I think we really would need to know are some community surveillance data pre and post pandemic on latent TB infection, and some other community surveillance data on asymptomatic or minimally symptomatic active TB in the community and how that's changed. But I don't know that, I've actually looked at that data early on, kind of the end of 2020, and I'm not aware of anyone who's published that data with any accuracy.
Thank you, Matt. So you have a question from Steve, but we're out of time. So if you can please just respond publicly in the chat, that would be great. Thank you.
Thanks, everyone.
Thank you, Matt. So next up is Saida Mahmood Tukri. And I just want to double check that her other committee members are on, because there was some before we start.
Yeah, I see that Lori's here and Jake is here as well.
Okay, great. Then the floor is yours, Saida.
Thank you. Is audio okay in video?
Yes.
Perfect. All right. Good morning, everyone. My name is Saida Mahmood. I'm an MPH student in the Department of Global Health. And today I will be presenting my thesis project titled Social Connectedness as a Moderator Between Post-Migration Stressors and Depression in a Sample of Displaced Persons. Before I go over my study, I would like to say that I am a Black Somali Muslim woman who was raised in the United States by Somali refugees and received formal education in the West. I do not know some of the direct psychosocial stressors displaced populations experience firsthand, but from my own lived experiences and working with displaced groups, I'm able to offer some conceptual ideas and insight. Here's a brief agenda. So currently we are witnessing a growing migration crisis that is alarming, which makes this study incredibly timely. There are now nearly 79.5 million people around the world who have been forcibly displaced, a number that has doubled in the last decade. Among them, 45.7 million are IDPs, 4.2 million are asylum seekers, and not listed here are stateless people, which has been estimated to be around 3.9 million, but this is known to be an underestimate, and a global figure of at least 10 million is often used. Much of the displacement can be contributed to conflict, persecution, and other crises. For displaced groups, migrating to an unfamiliar place is difficult and a tough reality to fully grasp. Displaced persons experience a multitude of hardship that includes racism, xenophobia, unfair political rhetoric, negative portrayal in the media, and hostility from local residents. Among displaced persons, there is a lack of research that examines social connectedness as a protective factor. Social connectedness refers to the degree in which a person feels close to another person or group. Oftentimes, there is a shared interest, culture, or lived experience which helps foster deep interpersonal relationships and social belonging. This study seeks to examine if social connectedness can serve as a buffer for depression, given the post-migration stressors experienced by displaced populations. The primary outcome of interest in the study were depressive symptoms. The predictor variables of interest were post-migration living difficulties and everyday discrimination. Both variables were examined separately and not in tandem, and social connectedness was examined as a potentially moderating variable. I will refer to the predictor variables as PMLD and EDS throughout the presentation. For our hypotheses, we predicted that higher levels of social connectedness would change the impact of PMLD on depressive symptoms in displaced groups, such that higher levels of social connectedness would be associated with lower depressive symptoms. Similarly, for our second hypothesis, we predicted that higher levels of social connectedness would change the impact of everyday discrimination on depressive symptoms in displaced groups, such that higher levels of social connectedness would be associated with lower depressive symptoms. This is a cross-sectional study which examined 4 measures related to displacement, post-migration stressors, and mental health outcomes. Data was collected through a series of self-report questionnaires in an online survey format via Qualtrics, completed through Amazon's Mechanical Turk, which is a crowdsourcing platform that relies on an online labor workforce. The Mturk page was linked directly through Qualtrics and retained no identifying information about the Mturk workers who were recruited as study participants. Anyone on Mturk on which users must be 18 years and older can access the initial screener. To advance to the main survey, the respondent must self-identify as a displaced person under UN definition. Respondents who do not self-identify in one of those categories will not advance to the main survey. Additionally, individuals who are not proficient in basic English did not meet the inclusion criteria for the study. We conducted our statistical analysis using SPSS 20 and Process Macro to run the moderation analysis, an interactive McCabe for data visualization. To assess for validity of responses, we omitted 35 samples who failed validity checks. We examined multicollinearity with our given variables and also performed a residual analysis to check regression model assumptions. All analyses were done at the significance level of 5%. The current sample we have that we analyzed is a subset of a larger sample that is currently still being collected. I will quickly review just some of the characteristics of our sample. As you see here, the table displays a baseline demographic information about the sample, which includes a range in total scoring for our variables of interest. Women were underrepresented in the study, and we had a diverse sample in regards to age, with responses ranging from 18 to 56 years old. In terms of PHQ-9, which looked at depression, participants endorsed mild to severe levels of depression. It's also important to note that countries of origin and residence listed here did not reflect the top hosting and top origin countries that were collected by UNHCR. So for our first aim, we saw that social connectedness moderated the relationship between PMLD and depression. When we're looking at our 95% confidence intervals, all failed to cross zero, so all conditional effects were significant. For our second aim, higher levels of everyday discrimination were not associated with high levels of depression. There was also a weak moderated effect. And looking at our confidence intervals here, all crossed zero, so none were statistically significant.
5 minutes.
This figure is looking at levels of social connectedness as a moderator between PMLD and depression. The dots are real people and where they score. Where you see more dots, there's more confidence in the relationship. On the y-axis is depression, which indicates the higher the score, the higher the depression. On the x-axis, we have PMLD, and these are mean-centered. So the score on 0 is the average amount of PMLD in the sample. As you see here on the top with the gray panels, those represent levels of social connectedness. So as a series of panels increase, it starts to illustrate a buffering effect on depression. As social connectedness increases, depression levels generally go down, and you see that line start to drop like a stair step. This tells us that social connectedness as a moderator is significant across the board, and that the relationship becomes stronger with higher levels of social connectedness. For our second figure, which looked at everyday discrimination, despite an overall significant model, we didn't see strong evidence at any level of social connectedness that it moderates the relationship between everyday discrimination and depression. And the overall relationship between EDS and depression in the sample was not there and was quite weak. So there's really no effect to really moderate. And this was a bit surprising to us, considering how counterintuitive it was to what we expected. So overall, we saw that higher post-PMLD was associated with high levels of depression, and that higher levels of EDS were not associated with high levels of depression. Overall, there was a moderated effect for both aims. For our second aim, the relationship between EDS and depression were weak, and this can potentially be explained by the fleeting nature of everyday discrimination. The experiences of everyday discrimination may lack the intensity of major experiences of discrimination, but nevertheless, they are still detrimental to mental health, as the chronic and cumulative nature of everyday discrimination can wear down or wither away an individual both mentally and physically. The moderating effect displayed between PMLD and social connectedness can be explained by the social capital theory, which is the exercise of reciprocal help, giving, and receiving, which is fundamental to the development and maintenance of social capital. This is important because as a result of displacement, familial and social dynamics have been ruptured, which can increase the risk of depression as well as exacerbate it. For many displaced populations, having community membership that is tailored towards their mutual experience can be socially, emotionally, and economically beneficial. Additionally, these interactions can help foster social connectedness and promote solidarity among displaced populations, which can have a greater overall robust effect on health and reduce depressive symptoms.
2 minutes.
Thank you. Although Mturk has been shown to have satisfactory internal reliability and retest reliability in mental health measures, there have also been critiques made regarding compensation and burnout by Mturk workers. Additionally, since Mturk can also be used for anything conceivable, tech companies do post tasks on Mturk to help train machine learning algorithms to flag offensive content, which can be disturbing to workers. The survey contains questions that the participants will have to think about retrospectively, which can result in recall bias. Voluntary participation as a result of convenient sampling can also lead to selection bias. Also, stateless groups were not fully represented in the study, so not belonging to a nation state can also influence types of responses given. And there was a level of English and computer literacy that was required, which is hard to measure even if that criteria is met. Expanding this type of study to include a more mixed methods approach can be helpful in uncovering new themes and experiences that may not be captured in surveys, since cross-sectional studies limit generalizability. This study can be helpful in establishing protective factors like social connectedness and risk factors for displaced groups at different periods of displacement. Pushing for less stringent policy on displaced populations can also help mitigate some of the proximal and distal stressors faced by displaced groups. And finally, we hope that this study can aid in using findings that can contribute to creating culturally relevant and congruent interventions aimed at ameliorating post-migration stressors and resultant mental health difficulties among displaced populations. I'd like to acknowledge my chair and committee members, Dr. Lori Zollner, Dr. Jacob Bentley, and Dr. Deepa Rao for their support throughout this whole process. I'd also like to extend my gratitude to the Islamic Trauma Healing Lab members, the Rao Lab members, CSSS, my DGH cohort, and my family and friends who are watching today. These are my references, and thank you. Mahadsanid.
Thank you so much, Saida. What a great presentation. And so nice to see the depth and the figures of this work and all coming together so quickly and so nicely. I'm gonna pause just because I know I'm a committee member, just to see if there are others who have questions.
Yeah, so Saida, you've got a lot of questions. So first is from Farah, who says, awesome job, Saida. Can you share a bit more about the Mturk tool and how it's used?
Yeah, so I did anticipate that coming up. So Mturk is a crowdsourcing platform that has grown in the most recent years. It has a huge global user base. It's been used a lot for research studies or anything really that can be conducted over the internet. And workers normally complete rapid fire tasks or surveys. I know there's been some critiques about payment, since sometimes they get paid well below the minimum wage. And since there's no global approximation for minimum wage, it's hard to figure out what an appropriate compensation is within the bounds of Mturk. But yeah, it's just a crowdsourcing platform run through Amazon where people can complete online tasks and surveys. And a lot of academics have started to use it more.
Awesome. Question from Anupa, who says, thank you for your work. I'm curious about the high levels of social connectedness being linked to low levels of PMLD/depression. If you have any additional thoughts on this, would love to hear it.
Yeah, so I wish I could have included some of the line items that were included in the PMLD survey scale. But a lot of the questions that measure asked talked about poverty, isolation, fears being sent back home, access, finding a job. And so we're assuming that when someone has high levels of social connectedness, that they have access to institutions, to people, to forms of support that can help assuage those post-migration concerns that they have. So those bonds and those bridges that are formed as a result of having either a shared identity or an affinity can be a remedy for post-migration living difficulties, and then in turn can reduce depression. So that's the relationship that we're assuming is taking place. But again, this is, this sample can't be generalized, but these are behaviors that and life experiences that we've observed and forced groups and other communities.
Great. We have a question from Gift, who says, do you think COVID impacted your study?
Yeah, so it's hard to know if COVID directly or indirectly impacted our study since it's conducted online. I do add that we did collect a measure that looked at adherence to CDC guidelines, as well as some behavioral insights into COVID-19 that we do plan to look at as a sub-analysis in my write-up. So I think it would be really interesting to examine, like theory-wise, like the spatial elements of social connectedness, if it's something that can be maintained remotely, or if it's something that only can flourish in a shared physical space. But we do plan to look at the COVID measure that we collected in our sub-analysis. But really relevant though, thank you.
Awesome. You have a question from Hani, who says, it's probably not in the scope of your thesis, but I was wondering why wasn't the survey developed into multiple languages, given that the targets are post-migration population?
Yeah, that's a really good question. So another limitation to consider. So I wasn't involved in the creation of the surveys. I do know my study collaborators who worked on a previous Mturk study included Arabic surveys, but I think if I had to answer, it was probably a matter of feasibility and time. But I do agree, including more languages that can help capture nuance and context that is missing is needed, and a good next step to take when creating more surveys. Definitely something to integrate.
Awesome. So two more. So one from Steve, who says, to what extent do you think your inclusion/exclusion criteria affected your sample, i.e., what part and characteristics of the target population might you have missed? How might it have affected your findings?
Yeah, so I mean, so we had our UN definitions, and people, self-identify. Someone who is an asylum seeker can, maybe click refugee, which may give us varying responses. I think with these type of surveys that look at displacement, it's really easy to capture, I think, responses from refugees or someone who might be an asylum seeker. But I think an important subset of that community that we often miss out on are IDP and people who are stateless. And in the past, there have been Mturk centers set up in UNHCR camps to help capture those responses. But I do think regardless of whenever you have an inclusion criteria, it is really limiting, and you will miss out on some subset of the population. But yeah, I think to go back to your question, which was, can you remind me the first part of the question?
Steve, do you want to ask your question?
Yeah, it basically, the people had to be in the Mturk, they had to be in, there were just a bunch of things that people had to be able to do.
Yeah.
And refugee populations are not always connected in that way.
Exactly.
So I'm just wondering, imagine the people that weren't reached in this whole process, would they be the same?
Yeah, I mean, you saw in the top countries of origin and countries where people are currently residing did not reflect some of the trends in displacement that we had hoped to observe. So I completely understand your question, and I know that Mturk can be limiting in that respect. I think just expanding these type of surveys to other online crowdsourcing platforms is a next step to help capture those responses. But yeah, it's really limiting and difficult, but we can definitely discuss in great detail too later. But great question.
Sounds good. All studies have these problems, so just
yes. Yes.
Great job.
Thank you.
I think Bernardo had his hand up the whole time.
Yeah,
I'm so sorry, Bernardo. Bernardo, if your question is short, we can take it.
We can make it quick. It's just thanks for presenting your models with the dots to see the actual presentations. That's observations. That's very nice. It seems to be some outliers there. Did you try several specifications, or did you check the effects of some of those outliers in your models?
Yeah, we had that conversation in great detail. So it's psychological data. It's really difficult because an outlier can just be someone who has severe levels of depression, and we don't necessarily want to omit that person from the sample because they can help tell us a story that isn't showing up right away. So we didn't omit any outliers, but we just omitted people who did not meet the validity check criteria. But we included all outliers.
Thank you so much, Saida. I'm betting, Nora, we're out of time, right? Or even past it.
Past time.
Yeah, okay.
Saida, definitely look at the chat. There's a lot of comments for you in the chat,
wow.
So please look at it.
Thank you, everyone.
Thank you, Saida. Great presentation. Next on the list is Cecilia Welch. So Cece, take it away.
Hi, everyone. Can you see my screen?
Yep.
You can't?
Yes, we can.
Oh, yes, you can. Okay.
Yes.
Okay, thanks everyone for joining me today. My name is Cecilia Welch. I'm an MPH and MS dual candidate. And my thesis title is Health Policy Approaches to Investment in Water, Sanitation, and Hygiene Infrastructure. So investment in better wash infrastructure has the power to significantly benefit livelihoods and economies. The Governing Sustainable Development Goal, SDG 6, says, ensure available and sustainable management of water and sanitation for all. Water, sanitation, hygiene infrastructure, policies and standards they're influenced by the SDGs, and they can heavily influence investments in wash infrastructure, contribute to how these services are accessed, and subsequently the health outcomes experienced by populations around the world. And it's well known that improved water and sanitation systems show a reduction in the prevalence of associated illnesses and mortality. And key agencies such as UNICEF and the World Health Organization follow the direction of the SDGs and are in leading positions to inform infrastructure decisions by pulling many sectors together. However, the investments made by leaders in the sector have remained unclear because the nature of wash-related problems and solutions is really complex. So one question I had was, how is this theoretical cascade reflected in the wash strategies of leading global health organizations? So this fueled the development of my research aims. First, I wanted to know how the policies of large multilateral health organizations described and invest in global wash infrastructure. Then, as I became more acquainted with the data, I introduced a secondary question, which is, to what extent are these wash investments driven by core values of ensuring health, protecting the natural environment, or pursuing equity? And before we get started, I'd like to state that this research process required that I define health as a state of physical well-being. Just help me code. I recognize my positionality behind this very rigid and learned definition as a result of my upbringing and education. And the reality is that there are many different, more expansive ways to think about health in other cultural contexts. This was a qualitative research design with two components, a document analysis and supplemental in-depth interviews. The organizations included were UNICEF, WHO, the Joint Monitoring Program, or JMP, and World Bank, and I'll expand on these choices later. Documents were all publicly available and found through an internet search or through archives and databases. The interview portion first required an IRB process, which once approved allowed for initial recruitment through a convenience sample identified through my committee and a snowball sample of additional participants. And I should mention that while these interviews were meant to supplement the documents, I decided to exclude them from the greater analysis. Then a detailed codebook was constructed based on an inductive coding approach that categorized codes into primary, secondary, and tertiary codes. And a series of intercoder reliability checks were performed with Cohen's kappa as the measure. And then finally, a more formalized document analysis was performed built on 3 themes based on the particular wash-related context. So a total of 36 strategy documents and 2 interviews were collected. UNICEF was a clear choice because they're well known as a global leader in on-the-ground wash efforts, and they had lots of publicly available documents. I included the WHO because they're often seen as the guiding hand in global health standards and wash standards. The Joint Monitoring Program was included because they are considered more of an initiative or team between UNICEF and WHO, and they work with essential wash data that influences investment decisions. And then the World Bank is not explicitly a health organization, but it does have enormous influence in global infrastructure development, so I thought that was important to include. And then finally, I conducted 2 in-depth interviews with 1 representative from UNICEF and 1 from JMP. The interviews were designed to be semi-structured, and I mainly wanted to know if the goals written in the documents were reflected in active projects. And a couple examples of questions were, how would you describe the role that your organization plays in wash infrastructure? And how is your organization's investment in wash changing? With a couple follow-ups. And as mentioned before, this was an inductive coding process that categorized text into primary, secondary, and tertiary codes to identify 1, broader wash categories, more technical aspects of WASH infrastructure, and finally priorities outlined in policy or capacity building roles, to name just a couple. And after three intercoder reliability checks, we reached a CAPA score of more than 0.7, and the code list on the right was finalized. So you can see within the primary code, investment in WASH infrastructure, secondary codes like drinking water, health, and health facility help describe the nature or intended target of the investment that the text described. And then sometimes tertiary codes were assigned, for example, under infrastructure co-benefits, or factors that were found tightly linked to WASH, such as education and equity. So with my results, I'll start off with some basic numbers. This table shows the codes that occurred with the most frequency across all organizations. For organizational roles relating to WASH, the most common included capacity building, policy and advocacy, and monitoring and surveillance. The most common aspects of WASH in the bottom part included equity, education, hygiene behavior, and health. And now moving on to the thematic analysis, text was grouped into three themes: health, environment, and society. The health theme described investment in WASH as clearly health focused or motivated from primarily a human health goal, for example, reduction in disease burden. The environment theme described investment as motivated by conserving the natural environment, specifically with protecting water resources and perhaps in the context of climate change. And then the final theme, society, described investment that was focused around social, political, economic, or cultural equity, such as improving poor menstrual hygiene infrastructure. And text was assigned 1, 2, or all 3 of these themes. And I included the combinations of these themes in pairs or all 3 because I found that WASH strategies were often discussed as having multiple core motivations that overlapped, and I wanted to show that in the results. And you can see that in this plot, which shows percent occurrence across all organizations. And then clearly the theme that appeared the most frequently was the combined theme health society, with health and society individually following in frequency. A different way to see this data is through integrated versus singular themes. So in this plot, the data are segregated based on if they were assigned only 1, 2, or all 3. And this shows that more than half of the content showed integration between themes, with about 43% singularly themed, which is still a significant amount. Theme occurrence was also grouped by organization. So here the singular themes are in purple and the integrated themes are in the gray. You can see that perhaps the most integrated organization is the World Bank, and the least integrated are UNICEF and WHO, which are the organizations that are more clearly labeled as health organizations. And a very small percentage in the dark gray there have policies, indicate that they have policies that are integrated by all 3 themes.
2 minutes.
So highlighting these joint themes, I'd like to share just a couple example quotes. First, Health Society from UNICEF. The UNICEF WASH response will prioritize support to women and girls who are at higher risk because they are the most likely to act as primary caregivers and water collectors, and are especially vulnerable when open defecation is the only sanitation option. And then skipping down to an example of all 3 from WHO. The diversity in the ecology and biology of disease vectors is important in conservation areas of wetlands and other aquatic ecosystems, where local communities may depend on ecosystem products and services, but also be exposed to the risks of vector-borne disease transmission. So there are some key takeaways that we can summarize from these results. 1, it can be seen from the thematic analysis that although a majority of the content showed that WASH is discussed from an integrated perspective, there's still a significant portion of WASH policy that is driven by distinctly singular values. And this indicates that the complexity of WASH may be recognized by these organizations, and that perhaps there's a shift happening towards interdisciplinary strategies. But on the flip side, they may still struggle to achieve truly integrated WASH strategies. And when looking back at SDG 6, the 2030 agenda is described as not only recognizing the human right to water, but also that, quote, social development and economic prosperity depend on the sustainable management of freshwater resources and ecosystems, end quote. So knowing this, it suggests that there is definitely room for more integration in WASH policy by health organizations, in order to align more with the SDGs and achieve a more resilient and healthy future. I'd like to thank my committee, Jessica Kaminsky, Johnny Crocker, Kenny Scher, and my good friend and coder helper, Kim Baker, who I couldn't have done this without. And here are my references. Thank you.
Thank you so much. Nice work. I'll just take a minute to pause for questions, or I could throw out my own. Maybe I'll do that since I'll just throw it out because it's a quick one. What are your plans for next steps and getting, disseminating your findings?
Yeah, I think one of the hurdles in this, I would have liked to include more interviews. So my next steps would probably be to try to reach out to more key informants for some more in-depth interviews to inform the document analysis.
Okay, thanks.
So Cece, I have a question from Steve who says, very nice analysis and presentation. Did you get a sense of how much financial investments aligned with the policies of these organizations?
Yeah, so one of my codes was financial support explicitly, and some organizations had more, explicit text saying that they would support financially the development of certain types of WASH infrastructure. I think UNICEF mentioned it quite a bit. WHO, they were more focused on policy and advocacy and capacity building. They didn't explicitly say much about like direct financial investment, but the World Bank definitely, they're all about that. So that was very explicit in there. Sorry if you can hear the rain, it's like really loud.
So Stephen Pope, who's an alum, says, really interesting presentation. I'm curious if any of the information you found during doc reviews or interviews was particularly interesting or stood out to you.
Yeah, the interviews were really informative, which is why I kind of wish I was able to include more. But particularly from the Joint Monitoring Program, they're really trying a lot, trying to work towards the integration of the SDGs in their data and analysis. And I think that quantifying inequities in like a really integrated way is really difficult, but they're doing a lot of good work behind that. And I just think that things will just become way more integrated. Things are just evolving constantly, and it was really interesting to hear about that.
Wonderful. Any last minute questions for Cece?
There's lots of positive remarks in the chat.
Yeah,
I hope we get a chance to look at.
Okay, thank you.
Great. Thank you so much, Cecilia, for your work. Really appreciate it.
Thank you. And thanks everybody who's presented so far. It's been really nice to hear the fruit of all your labors. We have 5 more to go, but we have a break now. Am I right, Nura?
Yep, we have a break.
Yeah, so please everybody feel free to turn off your cameras and mute yourselves and come back at 12:10. Grab a quick bite or
a little bit before 12:10, like 2 minutes before.
Okay, yeah, so we can just get started right at 12:10.
Yeah, exactly.
Sounds good. Thanks,
All
everybody.
Right, see you soon.
Okay.
Thank you. Share. Okay, great. Hi, everyone. My name is Natalie Gallus, and my thesis is on the estimation of childhood vaccine scale-up rates by country and vaccine. This work has been chaired by John Moser, and Mike Q is on my committee. Before starting, I'd like to recognize my position in doing this research as a white American female currently living in Seattle, Washington. I recognize the privileges that I hold with these identities, and also the privileges that I have as a graduate student here at UW, and the support and resources available to me from IHME. And I'll note that all my data analysis has been conducted remotely in Seattle, Washington, and that I personally have no in-country experience working on routine immunization systems. So to begin with some background, newer vaccines, including third dose hepatitis B, third dose Haemophilus influenza, second dose measles, third dose pneumococcal conjugate vaccine, first dose rubella, and the completed rotavirus series were not developed nor introduced into any national immunization systems until the early 2000s. This is in contrast to other vaccines like third dose DTP3 or third dose DTP and MCV1, which were introduced with the expanded program of immunization into most countries in the early 1970s. However, vaccine scale-up has been recognized as a global health priority, and this work has been primarily championed by Gavi. Gavi is an organization with funding from the Bill and Melinda Gates Foundation, and they primarily work in low middle income countries, working on vaccine scale-up and the development of new vaccines. Since their organization in 2000, they've contributed over $150 billion to this work. More recently, the Immunization Agenda 2030 has also recognized vaccine scale-up as a priority. They feature vaccine scale-up with two different objectives, one just being the introduction of all recommended vaccines into national schedules, and two, not just the introduction, but the rapid scale-up to over 90% coverage for these vaccines. However, while noted as objectives and known to be important, they currently don't have any standardized indicators or a global evaluation framework that's been decided. So as such, quantification of historical scale-up patterns certainly has value in quantifying where we are now and where we have to go to reach these objectives. And last, but certainly not least, a motivation for this work is that we know that vaccines work and they work really well, and we need equitable global and national coverage in order to reduce preventable morbidity and mortality. As such, for my thesis, I produced novel country and vaccine-specific estimates of scale-up, and then I also looked at how vaccine scale-up is associated with national immunization financing and Gavi support. For this work, I leveraged the GBD 2020 Release 1 estimates of national routine immunization coverage, which were produced from 1980 to 2019. I used survey microdata of vaccine coverage whenever possible, and in the absence of available microdata, I used survey report data. I also used bias-adjusted official country-reported data, which for the newer vaccines that I estimated comprised the bulk of my data set. I also used direct estimates of modeled DTP3 and MCV1 from the GBD to serve as reference vaccines, which I paired to each newer vaccine respectively based on overlapping recommended schedules. I also used the country-reported national vaccine introductions from the joint reporting form, and then I evaluated all scale-ups that occurred between 1980 and 2019 to align with the GBD estimation years. The modeling framework that I used for this was a meta-regression Bayesian regularized trimmed approach, also called Mr. BERT, and the specific features that I used was a cascading spline. And so broadly, the way that this works is first I fit a stage 1 global model using all the data that was available for each vaccine independently. Then, using the coefficient on the spline from the global model as a prior, I fit subsequent stage 2 location-specific models. Written formulaically, as is on the screen, what I was interested in estimating was P of T, so this was the vaccine coverage proportion for every individual new vaccine, controlling for X of T, which was the modeled reference vaccine coverage, so either DTP3 or MCV1 based on the schedule, and then I included a spline on the years of vaccine introduction. With my estimates of newer vaccine coverage, I was able to calculate scale-up ratios by taking the proportion of newer vaccine coverage over reference vaccine coverage, and I did this by location, vaccine, and year. Then I aligned these estimates from year of introduction to calendar year using the JRF country reports. To look at associations with national immunization financing and Gavi support, for national immunization financing, had access to estimates from 135 countries from 2000 to 2017, which were disaggregated by financing source and spending type. I used local regression to evaluate the association between the dollars spent per capita and then the scale up in the first year of introduction. For Gavi support, I compared countries that currently had Gavi support to countries that had Gavi support in the past and have since transitioned to countries that have never received Gavi support, and I evaluated the primary year that vaccine scale-up met or exceeded 95% of reference coverage.
5 minutes.
Thanks. So these are some of my results. As you can see on the left, this is just a short table tabulating the number of countries that had each vaccine introduced by 2019. Hep B and Hib had the broadest coverage in 2019 with just under 200 countries of the 204 total estimated with this vaccine introduced. On the right is a plot of the average scale-up curves for the first 5 years of introduction, looking at each of the 6 vaccines that I estimated. The x-axis of this plot is years of introduction, the y-axis is the scale-up ratio, and every color is a different vaccine. So as you can see here in orange at the top, RCV1 had the highest scale-up in the first year of introduction, but for many countries, the largest gains occurred between the first and second year. You can look at Rota-C in red, you can also look at the light blue line of Hib3. However, not all countries, or not all vaccines experience the same trends. And we can look at MCV2 in the green line below that had the lowest average scale up over the 5 years of introduction. So next, I compared the scale up proportions by types of government spending. These plots show log transformed dollars per capita in the year of vaccine introduction scaled to 2019 US dollars on the x-axis. The y-axis is the scale-up ratio, and each facet is a different category of government spending. The points are country and vaccine specific scale-ups. So these plots show that there's really high variation in scale-up across the distribution of different kinds of government spending. The curve that's here is the lowest regression with associated uncertainty in gray. And we can see that there's not a singular association between dollars spent and the scale-up ratio in the introduction year specifically. So the next 3 plots then show the relationship between or scale-up patterns looking at category of Gavi support, either currently supported, past supported, or never supported, faceted by vaccine, looking at the first 5 years of introduction. The x-axis here is again years of introduction, the y-axis is the scale-up ratio, and every facet is a different vaccine. The black line is the average scale-up across all the countries in every group, and the dashed vertical line marks the first year in which vaccine scale-up on average met or exceeded the 95% threshold. So among current Gavi supported countries, countries on average reach 95% scale-up within the first 5 years, with the exception of Hep B3 and MCV2. These trends are similar looking at countries with previous Gavi support, however, that's been pushed back for Hib3, PCV, and Rota-C, and still not met for Hep B3 and MCV2. Last, looking at countries that have never received Gavi support, they show the slowest scale-ups where only Hib3 and RCV1 reach scale-up within the first 5 years, and all others are still below this threshold.
2 minutes.
So ultimately, these results show that while nearly all countries have any nationally introduced newer vaccine at or above 95% scale-up, there's still work to be done. Only 75% of countries have all of their nationally introduced newer vaccines at or above the 95% scale-up threshold. And less than 40% even have all these 6 newer vaccines currently introduced. And so these results highlight that different vaccines have been facing different challenges, and vaccine delivery systems need to address and further recognize, then further assess, and then also come up with context-specific strategies so that these disparities can be reduced. And also currently, just by counts alone, the IA 2030 goals are ambitious. We're a long ways from reaching the goals for both introduction and scale-up. So there's work to be done this decade. And altogether, these results emphasize that and kind of point back to the overarching IA 2030 goal, which is a priority for equitable coverage. And we need robust monitoring and evaluation, tracking, and accountability. I'll note that this work certainly has limitations. For example, the model is not currently able to integrate and account for dose-specific or stock data constraints. Vaccine phase-outs or systemic declines or inclines really independent from the reference vaccine. I'll also note for this work that just looking at scale-up ratios, masks locations that have low underlying coverage, having low underlying coverage would still certainly qualify these countries to be priority countries for IA 2030's agendas and other national immunization goals. Another limitation is that I only reviewed country vaccines that introduced during GBD estimation years and only looked at routine vaccinations that are estimated by the GBD. And last, I'll flag that I can't use these covariate relationships as mechanisms to explain any country-specific scale-ups. With that, I would like to thank my committee, John and Wei, and also major thanks to the I2Me vaccines team, math science team, and the resource tracking team for their help with this work. Thank you.
Thank you, Natalie. Very interesting body of work that you presented. I do have a question, and probably you're going to anticipate it. And my guess is everybody in the audience has the same question, which is, do your findings have implications for COVAX and COVID-19 vaccine? And what are they? And what do we need to do to increase access? And I ask that because, you know, as we speak and as you were presenting, I'm getting yet another email from a friend and colleague whose parents over 65 have gotten first dose of vaccine in Nepal and are unable to get second dose. So this is a timely presentation. And so I'm wondering if your findings have implications for COVAX.
Yeah, thank you for the question. It's definitely, as you said, a very relevant question. I think that there are some major differences between the work that I've done on these childhood vaccines and also COVAX. One being the target age group and the population that we're looking at. One may think, and especially for doses that are routinely given out, it's much easier to pair these vaccines with other well child visits and things like that. So the system of delivery is very different. And so I think that's one limitation of directly transferring the work that I've done to something like COVAX. And then again, going back to the delivery mechanism, if it's a routinely administered dose as compared to what we have now for the COVID vaccines, which are much more mass delivery systems and things like that, and the procedures for still getting those doses available are, you know, worked out kind of like as we're running through that. So I think that those are two limitations to applying this work. But I think that there are certainly, like as we know for the COVID vaccines and as we see in other vaccination work, disparities in access and priority and privilege playing a role in that. And so I think future work definitely looking into the drivers of some of the trends for the scale-up patterns that we see in the childhood immunization coverage, I'm sure it could transfer into the patterns that we currently see now for the COVID disparities or COVID vaccine disparities.
Thank you.
Thank you, Natalie. So you have a question from Bernardo, who has his hand up.
Thanks, Nura. No, Natalie, very nice work. And I mean, I think your results really make sense that when you see some countries like under the microscope, that really is not a general problem for vaccines. They always struggle with one or two vaccines. So would it be possible like to make like clusters of countries, depending on where are they doing better or worse, like to have a more concise message and try to find solutions for some of them?
Yeah, I think so. I think that it could be interesting to also look, like as you said, and to see for what vaccine or vaccine combinations countries tend to do better for worse. For example, I might hypothesize that vaccines generally combined into pentavalent doses that are used in many countries might scale up faster. So that would include like Hep B3 and Hib, which is seen in some plots, as compared to maybe rotavirus and PCV that are independent vaccines. And so I think while every country has their own national immunization plan and every context is very specific, I think that there is value in continuing to look by geography and drawing strength from that.
Great. And last question is from Steve, who says, nice presentation. How well do you think the country reported coverage aligns with DHS estimates? Also, were all of these vaccines officially part of national norms?
Yeah, I will start from the end, or the second question. So yes, I only evaluated vaccines that were nationally introduced. So that excluded vaccines that were maybe only for like a specific subset of the population, maybe for travelers or immunocompromised or at-risk individuals. And then your question about the effectively bias perhaps between the official reported data and the survey data is a very good question. And one that we try to account for in our work. And so the approach that we've decided on is to actually implement a bias adjustment step where we look at the relationship between all of the reported coverage data with what's reported in surveys to effectively reduce or like adjust down coverage that we think is an overestimate and adjust upwards where we think coverage is an underestimate based on its relationship with survey data. And so for this work, I've integrated that bias adjusted data, if that was the answer to your question.
Yes, thank you.
Okay, thank you.
Great. Thank you so much, Natalie, for your presentation.
Great. Thanks so much. Excellent work. And next up is Shogofa Amini. So you have the floor.
Thank you. Let me share my screen. Oh, no. Can you see my screen now?
Yes, we can see it.
Good. Hello, everyone. Thank you so much for everyone coming for this presentation. My name is Shogofa Amini. I'm from Afghanistan. Today, I'm presenting my thesis is evaluating impact of men as a partner in change program in Mazar Sharif, Afghanistan. My committee, Christian Migret, and my thesis chair, and James Fiver is my thesis committee member. This is the outline. I will go through each one of these throughout my presentation. Before going into my presentation, I would like to accept my positionality, acknowledge that my positionality in this, throughout this project. I'm an Afghan woman. I was born and raised in Afghanistan, and I'm very much familiar with the culture and language. It was not difficult for me evaluating this program because the culture was, I was familiar with the culture. And I also see myself as a women's rights activist, especially in Afghanistan, especially working in this project is for me is important to see what ways I can do to help and reduce the domestic violence in Afghanistan. I also see myself as a graduate student at the University of Washington and working as a senior advisor at Sahar. This gives me an opportunity to use the resources and advantage to help my country in Afghanistan from here. Information about the background in Afghanistan. Afghanistan is located in Central Asia, and it's also, Afghanistan is a male-dominant Islamic society, and where the men are the more decision makers in the family. And honor is the fundamental Afghan culture. We often hear about domestic violence in Afghanistan, or it's increasing. And we hear the stories, but it's also important to see that we don't hear the other side of the story, like where the violence is coming and why the violence is happening. There are some studies been done that in countries like Afghanistan, in war zone countries, men who experience war and child abuse are more likely to commit acts of violence and abuse against women. After the 9/11, there are a lot of organizations went in Afghanistan working on women's rights, but they really missed the other side of the equation, is including men in the educational program. The challenges and concerns that men are more aggressive towards women because they feel insecure and excluded from educational program. Women prefer that their husband and their son should be included in educational program in order to understand the women's rights better. There are some programs and the studies been done. Expanding and including men in educational program may help to stop the cycle of domestic violence and emotional abuse. Sahar is one of the organizations doing a great work in Afghanistan, providing educational program for girls, and one of their highlight of work is early marriage prevention. And I had the privilege of working with them and help them to develop the Men as a Partner in Change program. And this program is provide training and seminar topics focused on changing male perception on girls' education and women's rights. In order to evaluate this program, I have 3 specific aims. My first aim is to see the effectiveness of this program by comparing a change in pre and post survey scores. My second aim is to see the acceptability of MPC program by evaluating the in-depth interview and focus group discussion within the participant in the program. And third aim is to see the challenges and barriers by doing the in-depth interview with staff. My conceptual framework, I choose the theory of action, which you can see in In the chart that we see the implementing of the program and then activities and our goals for short-term goals and long-term goals. For our short-term goals, we have to see how to change the attitudes of young men towards women's rights and domestic violence, how men become more advocate for women's rights. And for the longer term, we are looking at to see the higher rate of girls to attending in the class, and men become more aware of like gender, women's rights, gender awareness, and that will help to lower the rate in early marriages. For my method, I used the mixed method approach. Data collection was a mixed method, qualitative and quantitative. I use pre and post survey scores for students age 16 to 20. Enrolled at 4 weeks of MPC program, educational, administrated 3 schools, overall 45 students. For my qualitative part, AIM3 and AIM2, for my AIM2 in-depth interview was among 4 students that was done by my staff, MPC staff, and 3 discussion group was also done by staff, like within this 6 and 7 students. And IDIs with 6 IDIs with the staff was led by myself over the Zoom. With analyzing the IDIs and focus group was recorded 1 hour transcript and translated from Farsi to English. And it's one round coding, and I used thematic method to identify the themes and develop the code books.
4 minutes.
So for my results, for my AIM1, I see effectiveness of curriculums and promoting the change under the 3 domains: conflict resolution, domestic violence, and gender stereotype. Each domain was scored by 3 points. If the higher score shows the higher gender awareness, we see that there's a less significant in gender awareness, and more I see more changes on conflict resolution and domestic violence scores on that. For my AIM2, I have 3 themes. My first theme is try to see the acceptability of the program. So students really showed interest in accepting the program and really understanding about gender awareness, accepting the women's rights and domestic violence and male honor. One of the students said that I learned that being a man is not only providing financial support, a man also can be a partner to help his wife, his family, and his community. My second theme is the students really, we would try to see that how the program is really affecting their behavior change. The students' experience was positive. One of the students, this code really stood up to me, is that before MPC, I used to feel ashamed walking with my mother. I did not want my friends to see me with her, but now I feel proud walking by her side. I hold her hands. I do not care people are watching me. This is because MPC changed how I think about the women's rights. So overall, their perception about women's rights became more positive. And there are some topics that really stood up for them as like mental health, gender stereotype, bachaposh. Bachaposh is a term that mostly family dress up their daughter as a boy, and then they change back as a woman when she gets her period. So that's also affects then women's rights. So this code is like one of my favorite code, as just say that we need to bring some adjustment and definition of masculinity honor in Afghanistan. The real man honor is to support the woman's family and community in order to pave the way them to educate at work, not lock them at home as we lock a bird in a cage.
2 minutes.
So my third aim is to highlight the significant challenges that the staff came up with, is security, lack of space, improving technical skill, lack of training, and culture and traditional, which is we always see higher acceptance, but still there is some pushbacks from the community. For my limitation, there are some limitations because pre and post test survey is a secondary data analysis, and MPC program is not completed yet because it's the 2 years project. And there are some limitation translation because some words are like very hard to translate in English. Overall, my finding or discussion is that young men in Mazar Sharif who participate in the MPC program shows positive result and increased acceptability of curriculum and topics, especially awareness about the women's rights, conflict resolution, and domestic violence. IDI and focus group indicate that there is improvement on gender awareness and reflecting in changes and pre and post survey on gender awareness. We have to look at the questions on that. But the key changes that staff brought it up was lack of security, lack of resources, and there should be some more leadership development training. And definitely there is a security problem as well. Recommendation were made it revise pre and post survey questions in order to evaluate the curriculum topics. And also the program is still in the process and outcome is not clear yet. So overall, looking at this, since this is the first time implementing this program in Afghanistan, the outcome I can see so far is positive. At the end, I would like to acknowledge and appreciate my thesis committee. They really helped me through this project, and also Sahar organization who gave me the opportunity, and my team in Afghanistan, even though they're going through a lot of hard times, but they are still able to provide me the resources. And I am Department of Global Health, and I'm grateful and thankful for my friends and family who supported me throughout this thesis. Thank you.
Thank you, Shagofa. Nice work. So nice to see the final product. Well, I guess it's ongoing work, which is what leads to my first question, if I may ask the first question, which is your program is ongoing, and I wonder if your results pointed to any changes that you'd like to make to the men's partnership program. And the other thing I just wanted was a comment that your findings really pointed to the stigma that is just associated with women's gender identity, which is, you know, many of us who work in stigma associated with health or a health condition, or and often don't see the intersectionalities. And I thought your project really highlighted the just women's status and the stigma associated with that. But my question is more about the program and whether or not you will be making changes to the program based on this data.
Of course, like I said, this is an ongoing process, but I'm happy with the first time when we start this program, there was a lot of hesitation, and we also got some pushback. But with that comment, and there's a lot of quotes and that I see was positive response from young men. And this is something that involving young men for the first time in a kind of like very cultural, conservative communities. It's hard, but still you see that approaching, including young men, is a way that we can see the changes, and there is a hope that it brings changes to reduce the domestic violence.
Great. And Shagofa, you have a question from Miranda who asks, I'm wondering if you can discuss how the Sahar organization funds their work.
Their funding?
Yes.
Yes, they have. Especially with this project, we're partnering what's called Organization Women Strong. They're funding this specifically project for us. We're doing the work and they're funding the project.
Okay, thank you. And you have another question from Angela Chen, who says, such inspiring work. For future directions, how do you and your team plan on further implementing the program on a larger scale, knowing all the limitations you have mentioned?
Thank you. Yeah, our future goal is that we're now working only one part of Afghanistan, not part of Afghanistan, but our future goal is that if we work on curriculum and institutionalized, working with Ministry of Education, we definitely have opportunity to reach out bigger, like more schools involving mostly young peoples. So, training our staffs, definitely that came up, like training them about monitoring evaluation, one of the things that they have to be trained, because definitely there is a two system, like our system is a little bit different than there. So with that, if we improve it and work with the Ministry of Education, we can have more a positive outcome.
Sorry, I was on mute. So last question is from Steve, who says, great presentation. It seemed to me that there was a rather small improvement in post-test attitudes in your AIM 1. Did that surprise you? Also, to what extent do you think the Biden administration new Afghan policy will affect Sahar and MPC?
Great question, Steve. Yes, so my the first part of question that I had lower scores pre-post score, is it because it not surprises me, because some of the questions very sensitive, and still we should not forget that this is the first program we're implementing in Afghanistan with the Patriarchal Society. There is still a kind of like, I feel there was a confusion answering the question and gathering the all men together. That was kind of create a little bit sensitivity to get that answer. And the second part of the questions, like Sahar is really committed to staying longer in Afghanistan. Is one of the successful part of Sahar work is that their work is with the Afghan people. The project is really running by Afghan in Afghanistan. Like team, their office isn't based in Seattle, but their work is done by Afghans. Even the curriculum was developed by Afghans, and the work was getting done by Afghans. So that's why it's important to support team in Afghanistan and train them in a level that they have to continue in a ways of like make the work more sustainable.
Wonderful. Thank you so much for your presentation, Shagofa. Great job.
Thank you.
Thank you, Shagofa. And next we have Isabella Fabens.
Great.
So you have the floor, Isabella.
Thanks, Deepa. So I just wanted to say I've loved all the presentations I've seen this week. So thank you to all of the presenters. I'm assuming you can see my screen.
Yep.
Great. So my name is Isabella Fabens, and I'm a second-year MPH student in the Department of Global Health. My thesis is titled Determinants for Exposure to Mosquitoes and Bed Net Use Behavior in the Context of the New Nets Project in Rwanda. My committee members are Dr. Gabrielle O'Malley and Dr. Jim Kublin. This thesis project analyzed data from Rwanda. The prevalence of malaria in Rwanda was 7% in 2017, which is a bit lower than it is in neighboring countries, as you can see from the map below. Malaria prevalence has increased in recent years, and some reasons for this include emerging insecticide resistance and low coverage of insecticide-treated nets. Insecticide-treated nets, or ITNs, are one of the 4 essential interventions for malaria in most malaria endemic countries. ITNs act in 2 ways: block the transmission of malaria from human to mosquito and from mosquito to human, as you can see on the left, and kill mosquitoes that come into contact with nets. The figure on the right demonstrates that if many people in a community use nets, it can decrease the number of mosquitoes and how long they live. For the aims, generally mosquitoes that carry Plasmodium falciparum, the deadliest of the parasites that cause malaria, are known to bite at night. So we would like to understand what people are doing while mosquitoes are biting. For those who are not sleeping, what activities are they doing? And for those who are sleeping, are they using a net? And so the aims are to determine how daily activities are related to the risk of malaria transmission, specifically to understand what residents of the study villages are doing outside in the evening and when they might be exposed to mosquitoes. And 2, to understand decision-making regarding net use behaviors. For the methods, the parent study is the New Nets Project, which is testing out the effectiveness of new types of bed nets that may be able to kill insecticide-resistant mosquitoes. This thesis project analyzed qualitative anthropological data about net use in Rwanda. This is a map of the 3 districts that were chosen to participate in the study. Data were collected during the dry season in 2020. Participants were chosen from the study villages through purposive sampling and the chain referral method. Per district, there were 6 in-depth interviews and 1 focus group discussion for a total of 21 transcripts. For positionality, this is secondary data that was collected by researchers from Rwanda. I'm not considered a member of the community where the work was conducted. The interviews were conducted in Kinyarwanda, which is a language I don't speak. So I was only able to analyze the interviews once they had been transcribed and translated into English. I'm from the United States and have conducted the analysis from here. I am a white woman who is cis-presenting. And in terms of my education, I'm getting my master's degree, which puts me in a position of power. I'll now transition to talking about results. Aim 1 was to look at daily activities related to the risk of malaria transmission. This slide lists some activities that people engaged in during the nighttime that they did while outside of a mosquito net. In the codebook, a nighttime activity was defined as occurring between 6 p.m. and 6 a.m. Here's a quote about a nighttime activity. I may have got it from the hills where I could walk daily during that period. There is some work we were doing in the hills that required us to go very early and sometimes walking in the late night hours. So that's where I could have gotten mosquito bites, which caused that malaria. So aim 2 was to understand decision-making regarding net use behaviors. However, one of the biggest barriers to using a net was not having access to one. So I will discuss some of the findings regarding bed net acquisition. Of the participants who said how many nets they have, about half had at least one, and about half had enough bed nets to cover all of their sleeping spaces. Most participants received their nets through a government distribution, which provided nets for free to those in certain socioeconomic categories. Aside from the government distribution, it was difficult for participants to find nets elsewhere. And in some cases, participants were willing to buy a net, but there weren't any places where they could find one. Some other outlets for nets were that participants obtained them from antenatal clinic visits, or some participants bought them from residents of a nearby refugee camp. Most participants were able to identify mosquitoes as the cause of malaria, and many listed at least one prevention measure. Some of the environmental factors that the participants listed as contributing to more mosquitoes were bushes and swamps. And almost all participants reported having malaria. Some of the common prevention measures listed were using bed nets, maintaining sanitation and hygiene, clearing stagnant water, and closing doors and windows early in the evening so that mosquitoes wouldn't be able to enter the house.
5 minutes.
Here is a quote about measures a participant takes to prevent malaria. We prevent malaria in our homes by clearing bushes around our homes and also removing old jerry cans, pots, and other unused utensils in which water can be collected, and then serve as breeding sites for mosquitoes. We also have to cover all pits around the home where water can collect and serves as breeding sites for mosquitoes. Another measure is to sleep under bed nets always and closing windows early in the evening so that mosquitoes do not enter the house. For medical barriers to net use, issues with using the bed net include that some experienced irritation due to the chemical in the bed nets. Others said it was difficult to breathe well, especially for children. And some said that other people didn't use a net because it was too hot, but didn't cite that as a reason why they personally didn't use a net. Here is a quote about physical symptoms related to using a net. The challenges are many. For instance, there are some who sleep under bed nets and wake up in the morning having pruritic wheals all over the skin. Others sleep under them, and then they feel affected by the smell from it, and thus decide to remove it from the bed. For logistical barriers, one participant's children sleep on the floor, and it was difficult for them to hang the net so that the net didn't touch the children's faces. One barrier was finding ways to hang a rectangular net with multiple hanging points, which is similar to the illustration on the right. So most participants preferred a circular or conical net, which is similar to the illustration on the left. since it is easier to hang and it's possible to tie a rope from the center of the net to the roof. One participant said that their house only has one room and they sleep in the same room as where they cook. So the smoke turns the net black and they were not able to use the net anymore. Here is an example of issues with hanging a net. The challenge we have with the rectangular type of bed nets is that when you have a small house, finding where to hang the rectangular bed net becomes difficult. For example, you have a room in which there is a bed, a table where I take my meal, or sometimes with a cupboard. Hence, it becomes difficult to find ways of hanging the bed net. For the conclusion, most participants stated about malaria that were consistent with biomedical knowledge. As I stated before, some participants weren't able to receive nets from the government because they were from a socioeconomic category that wasn't allowed to receive nets. One idea to improve access is the government could provide nets to everyone, regardless of their socioeconomic status. In terms of medical barriers, other studies also found that participants' skin was irritated when touching nets, especially when participants had just received them. A recommendation from another study in Rwanda is that the government should include instructions about how to handle nets when they first come out of the package. As for logistical barriers, since participants in this study stated that conical nets were easier to use, it would make sense for the government to make sure that conical nets are available or to give participants a choice between types of nets. Looking forward, the New Nets project is being conducted over a period of 3 years. This was the first round of qualitative data collection in Rwanda, but qualitative data will be collected twice per year through 2022. Finally, I would like to thank all of the people who contributed to this project, the study participants, research assistants, the PATH Rwanda study directors, the PATH headquarters team, the funders, or the Bill and Melinda Gates Foundation, Unitaid, and Global Fund, an anthropologist at the Liverpool School of Medicine, one of the secondary coders, my thesis committee members, and finally, my cohort, friends, and family who have all supported me in this process. Thank you, and I look forward to hearing your questions.
Thanks, Isabella. Great presentation. Nice to see the completion of this work.
Thank you.
I do have a question, but I'm just pausing to see if there's any in the chat.
No one but Steve.
Okay, Steve, can I ask my question first? Or
Well, we have one from Gabrielle O'Malley.
Okay, all right, I won't. So
okay. Yeah.
Who goes first?
I'll do Gabrielle first. Okay, she says, wonderful job. Your work very nicely analyzed a first round of data collection early on in the New Nets project. Are there additional / different areas of inquiry you would suggest the project collect for the later rounds of qualitative data collection?
Yeah, that's a great question. And it's something I've thought a lot about. I was really lucky to work with the PATH team because they asked me for feedback on the interview guides with which they were collecting data. And one thing I noticed from a lot of other studies about bednet use is that they asked the participants themselves how they would improve the intervention. So I emailed my thoughts to the study team and they said that they'll definitely consider putting that into future guides since they're still kind of looking at the process for Rwanda and other countries. So it might make it into other guides as well.
Great. I'll read Steve's while it's here. Very nice presentation. Your interviews provided a lot of barriers to net acquisition and usage. I was struck that respondents said it was hard to obtain or even buy nets. Has that been seen throughout Rwanda or other countries?
Yeah, it's something I've seen in Rwanda. And what's interesting is that at this point, nets are distributed to people in certain socioeconomic categories. So one of the biggest barriers was that only some parts of the population were receiving nets. And so that's true, or at least it was true for the rest of the country. But now the Rwanda Biomedical Center has revised its practices so that at least there will be more nets per household that can receive them. So as before, there were, it was 1 net per every 2 people. And so now there will be 1 net per every sleeping space. And so one of my suggestions was to make it so that everyone, despite their socioeconomic status, could receive a net. In other countries, I'm not sure. I'm fairly aware that there are so many barriers in other countries, but I haven't really looked at what the barriers are in terms of who is getting the net distributed to them.
Oh, great. You have a question from one of your peers, Juan, who asks, would it be possible to connect your results with impact, and then in parentheses, I hope reduction, in the number of malaria cases after the project implementation?
Yeah, this is a good question. And what is interesting about the parent study is that there are a lot of different elements to the study. So I looked at anthropological data, but there's also entomological data. And so what the project is trying to do is understand what behaviors people are doing, and at the same time monitor mosquitoes to actually see when they're biting. So I'm not sure what portions of it address the impact of maybe a reduction in malaria, but I think some studies have looked at how nets hadn't been effective because they weren't, there was mosquito resistance to insecticide. And so I think the nets themselves there are some studies that have proved that they are effective. And so I think we're just gathering more evidence. So that is part of the study.
Great. And then you have another one from one of your peers, Gift, who says, great job. Did anything come up about the discomfort with the use of bed nets that may have been a factor for lack of use?
Yeah, and this is something that's really interesting. So as we saw in one of the quotes, it said that someone got pruritic wheals, which are kind of an allergic reaction to using nets. And other studies in Rwanda also found this too. So I think there are many different ways that it could be uncomfortable, but one is an allergic reaction. And a lot of participants, especially in other studies, a little bit less so in this one, stated that the net was too hot. And I guess I can speak from experience that it can get fairly hot inside the net if the heat is trapped in there. But it does seem that over time, with more education, people are still using the nets despite the fact that it could be hot.
Wonderful. Well, we're at time, but you have a couple questions and comments in the chat. If you could publicly get to it, that would be great.
Great, thank you.
Thank you. Sorry, Deepa.
Oh no, there's nothing to be sorry about. Thank you, Isabella. We are next up, we have Ingrid Zupcook.
Hello. Okay, let me just get things here. Okay, hopefully you can see that.
Yes.
Yeah. Okay, thank you. Hi, everybody. My name is Ingrid, and today I'm presenting on my thesis, which is titled Barriers to Nutrition-Related Chronic Disease Management in Kaqchikel-Speaking Communities in Guatemala, an exploratory analysis of cultural and linguistic factors. My thesis committee included Dr. James Piper, Dr. Meredith Forth, my mentor, community elder, and linguist Magda Sotz. So briefly to touch on my positionality, I am myself Indigenous Mayan. I'm Kaqchikel and Kaqchi. I speak 3 languages, English, Spanish, and Kaqchikel, and most of my education has been here in the United States since 7th grade. All of these things, of course, impacted the study that I conducted. So I'll go briefly over just some of the terminology that I'll be using. When I'm referring to NCDs, I'm talking about non-communicable diseases, often also known as chronic diseases. When I'm talking about the LAC region, specifically, it's Latin America and the Caribbean region. Kaqchikel is one of the 23 Mayan languages currently spoken in Guatemala, and it is the focus of this study. And then specifically to nutrition-related chronic diseases, for the scope of this study, we were interested in looking at diabetes, hypertension, cardiovascular disease, and some cancers. For the background, so in 2016, 71% of all global deaths reported were accounted for by NCDs. In the Latin American and Caribbean region, it is estimated that by 2030, about 81% of the deaths will be accounted for by NCDs. In Guatemala specifically, the country report of 2018 indicated that 59% of all deaths were due to NCDs. This is of particular concern given that Guatemala has a really high indigenous population. And although the data is very limited, the information that we do have, it shows that indigenous communities tend to be disproportionately affected by limiting barriers to their healthcare and their health outcomes. And this, of course, is not just in concern to Guatemala, but also the larger Latin American and Caribbean region, given that it is home to over 400 different indigenous groups. Of course, with being mostly congregated in 5 different countries, which include Bolivia, Guatemala, Ecuador, Peru, and Mexico, with Guatemala being the second highest concentration of indigenous population at 45%, speaking over 23 different Mayan languages. Specifically for Kaqchikel speakers, there's an approximate 500,000 people who currently speak Kaqchikel in the country of Guatemala, where the total population is about 16 million. And so that's a pretty significant number of people who speak the language still. To give you an overview of the linguistic regions of Guatemala, this is a map of Guatemala, and each region there in the different colors highlights a different indigenous language that's spoken. The language of interest for this study is Kaqchikel, which is the one circle in red there. I do want to make a note that even though these linguistic regions tend to be congregated in these areas, because of migration, seeking work and education, many indigenous people travel all over the country, and therefore the language is not limited to these specific regions. So for this study, I was really interested in learning about the major linguistic and cultural barriers that prevent indigenous patients in Guatemala from managing their nutrition-related chronic conditions. I wanted to see what role the Kaqchikel language plays in these barriers, and what is the common experience of nutrition-related chronic disease management in Kaqchikel linguistic communities. The 3 aims of this study were, first, to understand the role of language in healthcare delivery and chronic disease management among Kaqchikel health experts and community members. The second was to identify the key terms and language used to describe concepts such as chronic disease, health, and food, given that these are not words that necessarily exist in our language, but that we've had to learn and adapt for that reason. The third was to identify the similarities or differences in perspectives between stakeholders and community members. For the methods, we worked with a sample of 6 to 8 healthcare experts, 6 to 8 community members that were either patients or their family members. Our recruitment was purposive sampling, given that we were very strategic to recruit Kaqchikel speaking community members, experts that work in predominantly Kaqchikel speaking regions, or people that identify as Kaqchikel themselves. For the data collection, we conducted semi-structured interviews that lasted between 30 to 40 minutes. All the interviews were conducted either via Zoom or Skype, and it was done so by myself and my mentor, Magda. And so we recorded all the interviews, just the audio, not the video. For our data analysis, we used rapid identification of themes from audio recordings, given that Kaqchikel, even though it's still spoken by 500,000 people, is mostly a language that's passed down just orally. So we don't actually know, a lot of us don't know how to read or write it. And so there was really no point for us to transcribe, except for the quotes that we were interested in that highlighted some of our themes. So a little bit more about the data analysis. The form that you see there on the left was our form that we used to conduct our analysis. And what I'm presenting today is a preliminary analysis because we only have the data that we conducted with our health experts. We conducted a total of 8 interviews. Out of the 8 interviews, 6 were in Kaqchikel Maya. All of our questions were designed in Kaqchikel Maya. And the one that you see here on the board is actually in Spanish. And then 2 of the other interviews were conducted bilingually. So either Spanish and Kaqchikel and Spanish and Quiche, which is another indigenous language that's pretty close to Kaqchikel.
4 minutes.
Again, we used RITA, so rapid identification of themes from audio. There were 2 coders, myself and my mentor, Magda. We conducted 2 rounds of coding, and we listened to the audios in Kaqchikel and basically drew out the themes in Spanish, which is the language that we both commonly speak as well. So from our preliminary findings from health experts, these are the 4 key ideas that we kept seeing throughout the interviews. The first one is that most health experts recognize that health encompasses more than the Western definition when treating indigenous patients. The second is that there's a few barriers to nutrition-related chronic disease management, which include language barriers. access to land and ancestral foods, wartime trauma like displacement, starvation, and poverty, which is not only from the war that ended in 1996, but many of them dated back all the way to 500 plus years since colonization. The second is the heavy marketing and easy access to cheap processed foods, even in some of the most remote areas of the indigenous communities reside. The third is that eating these foods and fast food, highly processed foods is seen as a fad. It symbolizes status and power, which is in great contrast with the discrimination and racism that indigenous people face when we eat our traditional foods. And fourth, of course, is that language is key to disease management and is essential to building trust with medical providers. Here I show a quote. This is what we transcribed. At the top there is Kakchikil, and at the bottom is the English. And this is what one of our health experts said pertaining to the first theme. There are three ways that we understand health according to our ancestors. First is our destiny, what we were born to do and what we need to fulfill. Second is our physical health, our bones, our muscles, our hair, our eyesight, everything we can touch. And third is the relationship, as our ancestors described it, relationships with our community and our family. So here we see that a lot of what Western medicine focuses on is the second, which is the physical health, which is what a lot of indigenous health experts really pointed at.
2 minutes.
The other one is this quote pertaining to language being key to disease management. The health expert said, as I was explaining to you, Kakchikil is very useful to me. It allows me to help my community. I have a sign outside my clinic and it says, I can provide services in our language, Kakchikil, and in Spanish. And with just that, people get excited because they often say, here they will value and hear me. I'm a native speaker. Others learn the language, but their understanding of culture is limited. There's much that they don't understand, or they use words that we don't use. And I speak like our people speak. So some of the implications of this study, as I'm very much interested in this, and I hope to continue this, to expand this study in my PhD work. But the first one is that there's quite a few implications for chronic disease programs in education, given that currently most of them are conducted in Spanish. The second is the importance of understanding language in public health interventions. I think one thing that's worth highlighting is just how much trust we can build when we speak the same language. And that often came up during our interviews. A second thing to highlight here is that language erasure has been a very strategic goal of colonization for that reason, because language is so central to indigenous identity. And so as public health experts, I really do feel like we need to start incorporating this to not contribute to the erasure of indigenous languages across the world. So for my next steps, we will be interviewing community members. We expect to interview between 6 and 8 community members. We hope to use the vocabulary in Kakchikil that we gathered from our indigenous health experts to conduct our interviews with community members. We want to see if community members identify the same barriers to disease management as health experts did. And of course, share these findings with not only our participants, but also stakeholders to actually bring about great health outcomes for our indigenous community. And with that, I want to acknowledge, of course, first and foremost, Kawinak, my people, for allowing me to draw some of this knowledge from all the health experts that I interviewed, my thesis committee for their ongoing support, the Department of Global Health, the Instituto de Nutrición de Centroamérica y Panamá, INCAP, since from doing my practicum with them is where the idea for this thesis was really solidified. And of course, my family and friends who have provided just incredible support throughout my time here at the UW. Thank you, Matios.
Thank you so much, Ingrid. What a fabulous presentation. I'm itching to ask the first question. So if it's okay, I will do that. And my question is really prompted by an argument that one of our alum and current PhD student in anthropology has asked in the past, Hugo Puerto, and that, do your results point to the need for a separate system of Indigenous healthcare, or might it be possible for us to even out power differentials in the healthcare system so that, you know, healthcare workers take the role of learner rather than kind of a top-down system? I wonder what your results might say about that kind of dilemma that we face.
Right. Thank you, Deepa. Well, it is worth highlighting that about half of the health experts that we interviewed, they're Indigenous themselves, speaking more than 2 languages sometimes, and both have Western education, but also education within our ancestral medical knowledge. And so I think looking at the integration and the collaboration that happens there and what is possible, I think is also worth noting. I think there's a lot to be said for that collaboration, since I think it is the key to really improving a lot of health outcomes for our communities. But I think the most important part there is that, it continues to be leadership that comes from the community. As our health expert highlighted, that even though, we can learn the language and we can pass on certain knowledge, it's very different when you're from the community and you were born with these concepts and knowledge, and you can constantly draw on them, so that there's just a very common understanding when we're serving patients in the region.
Thank you.
So let's see. Okay, so there's a question from Isabella who says, thank you, Ingrid, an incredible presentation. I'm so interested in language access and what you said about language erasure. What can be done to improve access in terms of languages, and have you been involved in advocacy surrounding, I don't want to butcher the name, yeah.
Kachikil, yes. Yes, thank you, Isabella. Great question. And the answer is yes. I've been really heavily involved. I'm pretty passionate about preserving language. And I think it differs, right, depending on the country. Specifically for the context of Guatemala, the government, after the signing of the peace accords in 1996, included in that promise that Indigenous education would be bilingual for the different areas, encompassing all 23 different languages. Yet we've been waiting over 20 years for that promise to be fulfilled, because it's not happening. And so I think that continues to be a significant barrier why we don't see health experts in this field. But as of now, there is a pretty big, part now of a small but growing number of Maya scholars who are really passionate about this and really including that. And so I think part of the work that we do as public health is also really acknowledging that language plays a huge role. And it's not enough to just, work with translators, but it is more than that. It requires us empowering communities as well to have access to those things in order for them to be active participants in the research that we conduct.
Beautiful. I have 2 more questions. So one from Steve, who said, great presentation. You do a wonderful job at highlighting the importance of language and health. Is Quechua the most commonly spoken Mayan language? And do Guatemalan people often speak more than one Mayan language? And third question, is there trading or mixed or Creole languages that cross ethnicities?
Thank you. Yes, I'll try to get to all those 3. The first one is that, yes, Kachikil is among the top 3 most common languages spoken in Guatemala. So the other one is Quiche and Kekchi. And then, oh gosh, I think I forgot.
Then is Kachikil the most spoken Mayan language, and do Guatemalan people often speak more than one Mayan language?
Yes, they do. So, a lot of people speak, for example, in Solola, where I'm from, it is common. We're surrounded by 4 different Mayan languages, and some of them are drastically different. And so because of work, we are required sometimes to kind of learn on our own those languages. But again, it also just, you have to choose to do that for yourself. It's not even something that sometimes is required, especially for government jobs. Sometimes it's not a requirement to obtain the language acquisition, even if you're working in those heavily spoken languages. And so that's definitely a problem. In terms of the other one is that Garifuna is the other language that's spoken in the country, which is from an Afro-descendant group that currently resides in Guatemala. And so there is a lot of language exchanges, especially with the Mayan groups and the other groups that exist in the country. There's a lot of solidarity and a lot of work that we do together to really bring this about, that it needs to be a priority for the government, especially when we make up almost 55-60% of the population by Indigenous organization estimates.
Lovely. So I'm going to squeeze in Bernardo's question. It says, very nice work. There has been a lot of work in the area of nutrition in Guatemala, including Indigenous communities. Any lessons or differences to the case of non-communicable diseases?
Yeah, thank you, Bernardo, for that question. Yeah, this is one of the unfortunate things that happens in Guatemala. Over the last few years, it's been really difficult to see that those numbers have not really changed, especially for the rates of malnutrition in is predominantly indigenous communities. And I think a lot of it is also tied to just money. It's really hard to buy these types of products. One thing that we found interesting in our studies as well is that even though people may have some land, often what they grow and what they plant and cultivate, they rather sell because maybe that gives them a little bit more money to buy cheaper foods. I mean, one thing that we also highlighted in the interviews was that a lot of our health experts said you go to the most remote indigenous communities that barely have even like a health post, but you will definitely find 2 or 3 stores that sell, instant soups, and they'll sell, really sugary drinks. And so like what the priority is there, not only for our country, but also just for these companies is very obvious, right? And so people have to, at the end of the day, make decisions that how they're going to feed their families. And I think that is also impacting that. But I do hope that with this, we integrate more leadership, because I think there's some of the things that we learned from this study is that there are ways that we can communicate in our language that really also empower people to go back to our ancestral foods, even with that really hard history of discrimination and racism because we ate those foods.
Wow, very beautiful. Thank you so much. You've got some really great comments in the chat, so please take a look at that as well. Thank you, Ingrid.
Thank you.
Okay, so next up is Farah Khan. So you have the floor.
Okay, great. Thank you, Deepa. Let me just share my screen. Can everyone see this?
Yes.
Okay, great. Hi, everyone. Thank you for being here today. I am Farah Khan, and I will be presenting the preliminary results of my thesis research, a systematic review of the mental health impact of stigma and discrimination of South Asian religious minorities. My thesis chair is Dr. Deepa Rao, and my committee member is Amritha Bhatt. So research shows that there is a direct link between racism and health, and specifically looking at mental health, that exposure to racial discrimination can lead to higher risk of depression, anxiety, and chronic stress. The additional layer of religious discrimination and its link to health has not been a large focus of research. In the past decade, in both the US and the UK, there has been a documented increase in xenophobic hostility and an increase in hate crimes against South Asians, especially those who identify as Muslim or Sikh, or those perceived or racialized to be a member of these religions. Additionally, mental health care providers who are often members of the dominant culture can hold stigmatizing views of South Asian culture and religion and lack the cultural responsiveness and training needed to adequately care for these patients. So to formulate the research question and aim, I initially conducted a literature review and noted recurring topics around experiences of mental health challenges, discrimination, and the South Asian diaspora. Based off of these findings, the research question I formulated is, what is the impact on mental health of stigma and discrimination against South Asian religious minorities in predominantly white, English-speaking Christian countries? For the purpose of this research, I defined South Asians as members of the diaspora originating from Afghanistan, Bangladesh, Bhutan, India, Pakistan, Nepal, and Sri Lanka. The countries included in the search described as predominantly white, English-speaking Christian countries are the United States, the United Kingdom, Canada, and Australia. Before moving forward, I want to acknowledge my positionality as it relates to this research. I am the daughter of Pakistani immigrants and was raised for most of my childhood in the Muslim faith. I have grown up and been educated in the United States and therefore do not directly identify as a member of the initial South Asian diaspora, nor as a South Asian immigrant. In regards to the mental health effects of acculturation and integration stressors and of the experiences of members of other religions, I have relied more on study findings than on my own personal knowledge and experiences. So for the data collection process, I entered search terms into 5 electronic databases. I included all papers that resulted from the original Boolean search formula, which also became the inclusion criteria. I used the Covidence software to remove duplicate articles, perform a title and abstract screening, followed by a full text review to extract and organize information from articles. Because of the focus on mental health impact, I use primarily health-based databases in our search. To ensure rigor and quality assessment, a second reviewer was involved during both the abstract and full text review, and discrepancies between myself and the second reviewer were resolved through discussion with the thesis chair and further refinement of the inclusion and exclusion criteria. After identifying a list of relevant records and removing duplicates, 867 titles remained for title, abstract, and full text screening. We retained 191 articles after abstract screening and 99 articles after full text screening. And the final number of articles for data analysis was 97. For the analysis of the data, I used content analysis and code counting. The codebook was developed after reviewing the final batch of articles and through a social determinants of health framework. We used deductive coding, adjusting the codebook during multiple phases of consensus coding between myself and another student researcher to ensure consistency and establish common themes. We logged descriptive and conceptual codes in an Excel matrix. So the current analysis consists of 41 coded articles, and after eliminating duplicates and articles that meet the exclusion criteria, there are 90 articles total for the final review. Of the currently coded studies, 19 were qualitative studies, 17 were quantitative, and 5 were mixed methods. The most common countries of origin in the studies were India, Pakistan, and Bangladesh. Islam was the most common religion discussed in the studies, followed by Hinduism, Sikhism, Jainism, and several studies that did not specify a religious population. Most of the studies were published within the last 10 years and took place in the United States and the United Kingdom. As a result of the analysis of this data, 4 major themes emerged. These themes relate to acculturation stress, elements that provide a buffer from associated psychological distress, stigma and bias, and access to mental health care services.
5 minutes.
Thank you. Theme 1 discusses acculturative stress, which describes the reactions to the process of cultural adaptation, where individuals grasp and absorb values, beliefs, and behaviors of the new culture. This finding suggests that acculturative stress, more than a response to adapting to a new culture, is in part exacerbated by experiences of discrimination and being stigmatized. In the findings, acculturative stress offered an additional layer of negative impact on mental health for members of South Asian religious minority groups, as the experiences of immigration and resettlement involved anti-immigrant and xenophobic sentiment, being excluded from support systems such as parent-teacher associations or job search support, and pressures of learning a new language. Theme 2 describes the buffers of psychological distress. Specifically, according to the findings, though experiences of discrimination were associated with higher depressive symptoms, anxiety, and stress, more traditional practices and an active coping style buffered some of these associations. These included religious and cultural practice, such as attending services in a mosque or temple, abiding by cultural scripts, such as hospitality towards elders, preserving family honor by avoiding gossip, and having family close by or living under the same roof. Theme 3 describes the interpersonal, ecological, and institutional forms of discrimination and stigma towards this population and the associated mental health challenges. According to the findings, religious discrimination, stereotyping, and mistreatment by representatives of host systems, including landlords, health providers, and educators, negatively influence coping styles and were associated with increased stress and fear of potential discrimination. Lastly, theme 4 is still emerging, but the current findings discuss religious discrimination to be a barrier to accessing mental health care. The limitations of this systematic review are first, that the generalizability of the findings may be restricted due to the process of article selection, the number and types of databases used, the non-inclusion of theses and dissertations, and the non-inclusion of studies not reported in English. The scope of the inclusion and exclusion criteria evolved throughout the article screening and the review process, which may have resulted in selection bias. The study did not assess the role of mental health stigma within South Asian populations, which likely also influences mental health impact. And lastly, the parameters of the search for articles was difficult to establish considering the racialization of religion, which makes it difficult to define Muslims and non-Muslim groups who experience Islamophobia. In conclusion, although this is an area of research that is new and developing, the increasing number of studies in the past decade coincides with a rise in religious discrimination and stigma against South Asian religious groups associated with an increase in mental health challenges. Additionally, much of the research does not take into consideration the heterogeneity of South Asians. Future studies should adopt an intersectional approach that examines the differences in subpopulations of religion, language, caste, and country of origin. Lastly, the findings of this research highlight a dire need for more culturally responsive training for mental health providers and better investment in engaging recent immigrant populations in job support, language acquisition, and social programming. I want to thank my thesis committee for their guidance throughout this process, to my co-coder and co-reviewer for their contribution to this research, to the UW-UBC Mobility Award co-collaborator, and my wonderful MPH cohort, and to my family and friends for all of their motivation and support. Thank you very much.
Hey, thank you, Farah. Fabulous presentation. Okay, so I'm going to pause since I'm your chair. I probably should refrain from asking the first question.
So, okay, so we have a question from Saida who says, excellent job. How did you narrow down the databases the databases you used for the review?
So before I started the review, I met with a health sciences librarian and shared a bit of the background literature review that I had done and what we wanted to look at as part of the research grant that funded a part of this research. And so that librarian helped me figure out beyond just PsycNet and PubMed, beyond like the health databases, other databases that involve social science articles as well as anthropology articles that we wanted to include.
Great, and you have another question from Hani who says, great presentation and important work. What do you plan on doing with the results?
Yeah, that's a good question. So I believe that we will eventually publish this, and also that there has been discussion about submitting abstracts to a couple of conferences, including SACPAN, which is the South Asia Pacific Northwest Conference that is conducted between Portland, Seattle, and Vancouver every year. So that will definitely be an option. And I think we'll probably work with my thesis chair and figure out other ways to disseminate these results.
Yeah, could I add, Farah, that we'll also be, the funds were provided to strengthen collaborations between UW and UBC, and Rabinder Bedi, who's actually here, it will be brought in and we'll discuss further dissemination with him. Rob is from UBC and will be a co-author on the final manuscript. So it's been a nice kind of avenue for us to collaborate across borders, even when the borders are closed.
So Farah, you have a question from Steve who says, great presentation. Were the articles recent enough to get a sense of the impact on mental health of the recent increases in religious bigotry by Modi, Trump, and others?
Yeah, that's a good question. So it's definitely something that I'm seeing more and more articles from 2020, 2019. Specifically, there was a systematic review done on Islamophobia and public health from 2020 that specifically referenced the Muslim ban. So I do think that that's probably an emerging area of research that we're going to see around the mental health impact as well.
Great. Deepa, do you want to go ahead and ask your question?
Oh no, I didn't have one, don't worry.
Oh, okay. Okay, so there's a question from Rob who says, nice work. I'm wondering if you could say more about how you selected the mental health terms used in the search. i.e. anxiety, depression, mental health, etc. I know that there are so many different words, diagnoses, disorders that cover mental health conditions / experiences, and many articles do not use the term mental health, but rather mention the specific disorder beyond depression and anxiety.
Yeah, definitely. That's a great question and likely a limitation for this study. We tried to encompass, if you saw the Boolean search term, it's very long. We tried to encompass beyond just the regular mood disorders, stress, psychological distress, acculturation stress. But I do think that that will probably be a limitation because there's only so many ways that these different bodies of research define mental health impact or negative mental health impact.
Fabulous. Well, that's all the questions in the chat box.
Okay, well, thank you, Farah, for your wonderful presentation. And believe it or not, that concludes our MPH thesis presentations for the Department of Global Health. I have many kudos and acknowledgements to kind of go through. First of all, I wanted to thank all of the students for your extreme hard work and patience with a multitude of challenges. I and others from the MPH program team are so proud of you and all that you've accomplished. So thank you so much for bearing with us. And it's so nice to see the completion of all of your hard work in these presentations. So huge. I mean, I wish we could have such a loud clapping session here, but I don't think that would work on Zoom. But I also wanted to just mention that the presentations over the last 3 days so nicely highlighted the benefits of looking at things qualitatively and quantitatively. You know, that we heard presentations that were so strong and with mixed methods and all had impact and value. And that was just such a pleasure to hear. In terms of thank yous, I do want to give a special shout out and thanks to Noura Yusufa for so smoothly organizing the past 3 days and helping with moderation. It takes a lot of energy and work to do that. So thank you so much, Noura. And also special thanks to Andreas Keodara, who did a lot of work in individual meetings and group meetings and communication through so many different sectors to just make sure that people are graduating on time with all of the constraints that we've had over the last year. So thank you so much, Andreas. And as I said at the start, special thanks to Julie Burnett for really leading our MPH team. She organizes all of us and the students, and I am and will be forever grateful for your time and efforts. Also, I want to acknowledge we have been so thrilled to see family members and friends join in and mentors from a distance. We welcome your presence here, and we're so honored to have you. So thankful you were able to join. There are some benefits to Zoom in that we can bring in people from everywhere, all over the globe, and we really benefited so much from that over the last 3 days. So thank you for coming. And to the mentors who spent all of their time and efforts with you, students, and trying to kind of see your work to fruition. We acknowledge all of your efforts here today. Thank you so much for all that you do. And yeah, with that, I don't know, Steve, if you have any other words as the director of our MPH program.
Sure. First of all, thanks to you, because you've done such a wonderful job of helping so many people get through their thesis projects. I mean, your name is everywhere in this, and I don't think we could have done it without your leadership in this respect. So a huge heartfelt thanks to you, as well as echoing the thanks to Noura and Julie and Andreas, who are just superstars. And then finally, just to say that we have never had a class in the MPH program that has gone through so much disruption as yours. You know, you guys have been in a situation where what you expected when you came in just got completely turned on its head, by February and March of last year. And you have been so cool in managing that, just in terms of dealing with anything from the workshops to the, to the way that you had to, change your direction oftentimes in your thesis work, where you actually couldn't go places, or you got a grant and you couldn't go to the place where you got a grant, or you needed to do interviews and you had to do them on Zoom or do completely different thesis projects. And that's really amazing. And I'm so proud of all of you guys in being able to manage this with just really fabulous thesis projects with a tremendous contribution to public health. And as Deepa says, just something that makes us all proud. So congratulations to all of you.
Yes, and may I add,
Thank you,
also
fearless leader.
May I also add Bernardo and Sarah. Sarah couldn't make it to today's session, but Bernardo, thanks for leading yesterday's and also being a great advisor, faculty, all of those great things.
Yes, and for incorporating IHME in. Thanks, Nora.
Yay! So with that, we'll end. I know this is always one of the hardest moments, but we will see you. And graduation, I believe, is in 2 weeks, and we'll see you again there.
Yes, I will have all these recordings by tomorrow, hopefully. And so you can send it out to whomever you want or rewatch yourself just rocking it. So yes, thank you all.
I see Hani behind sight sneaking in. Thank you all.
Goodbye.
Bye.